first, okay, Jairani, please.
Yeah, you are
definitely the number one.
You are the chief guest.
No doubt, number one, Nandita. No, don't keep the chief guest last. Because
you are the no. In webinar, it's the reverse, madam. The chief guest starts the program. For me, you are always the best.
Thank you.
We are live now, ma'am.
Mona, you can start, dear.
Good evening. It's a great pleasure to welcome all for this scientific session. We all know that the World IVF Day is observed every year to commemorate the birth of first IVF baby on July 25th, 1978. On this week, we, the OXY and the AMOGs, are proud to organize the webinar on advanced ART. We start our webinar with Tamil Thai Valthu. Light is the symbol of brightness and prosperity. Let's join. Light is a symbol of brightness and prosperity. Let's join for the auspicious lamp lighting. I welcome Dr. Kundavi ma'am, our secretary OXY, to render the OXY prayer.
Thanks, Mohna. Thank you, God. In humility we gather. In gratitude we pray for all the good things you have given us. Shower us with your blessings to pass on the healing touch, to celebrate the arrival of each new life and a mom reborn. The courage to deal with it all when things are not perfect, and to remember that we are but messengers to keep our women safe and free from sorrow. We bow before your kindness and the magnanimity of your endless love. Thank you.
I welcome the conveners, Dr. Kalyan Barmade, the President AMOGS. Sir was a chairperson Public Awareness Committee FOGSI between 2019 and 22. He is a joint secretary IAG. Sir is a convener Mission Save the Uterus FOGSI 2019 to 22. Welcome, sir. I welcome our President OXY, Dr. Jairani Kamaraj ma'am, who works 24/7 with her selfless motherly affection to strengthen our society activities. Madam, she is currently the President of OXY, South Zone. She is the Associate Secretary, World Association for Sexual Health. She is an active member of FOGSI Sexual Health Committee for the past 10 years. I request Madam to render the welcome speech and for the further proceedings.
Thank you, Mohana. Thank you. Thank you, God. We start this nice webinar with a very eminent, very much enthusiastic, lively and lovely and very much pleasant chief guest, Dr. Nandita Madam. We welcome you, Madam. I have the great pleasure and honor to welcome the chief guest, Dr. Nandita, who is well known to everyone, who is like a dream person for almost the ESAR as well as the Foxy. And we have a great pleasure to have her in all the forum with a dynamic work, what she rendered in Foxy as well as in the ESAR. She's presently the president of ESAR, and she's a fellowship. She has a lot of teaching, PG teacher, delivered more than 85 orations, and she has been specialized in the IVF ART in the world, in many of the world famous IVF units. And she is the president of IAG between 2017 and 18. And she has been president of almost all the societies all over our country. And she's well known for her dynamic work for the Foxians as well as for the fertility specialists. And Madam, over to you to say a few words to felicitate this occasion, ma'am, this webinar.
Thank you, Jairani. I think first of all, congratulations, Oxy and Amox, for having come together to do this. Dr. Pardesi, President of Amox, my dear friend and my Vice President, I think a dynamic personality, Dr. Jairani, President of the OGSSI. I think another dynamic personality who is very forward-looking and very hardworking, as Mohan actually said, and working very hard. Of course, Ashwath, I cannot forget, who was my vice president, and very creative personality and very dynamic person. Dr. Ramni Devi, my really somebody whom I've grown up with in Foxy, somebody very close and whose immense knowledge I really respect. Kalyan Barmade, a young individual who has shown such immense potential and who has, taken the confidence which all people showed in him. And today he's the secretary of IAG, and he will soon become the president. And I'm really looking forward to his year as the president. So Kalyan, looking forward to great work from you. I can see Priya Kannan, the past president of the ACE. Priya, at such a young age, you really achieved an amazing job. And Parshuram, my young Turk, and not so young anymore. I think he's achieved his own thing in his own way. I'm on this mobile, so it's really difficult to find people. And Kundavi, who's the secretary. I think, being in IVF is something really fantastic. The technology today is like at its peak with artificial intelligence coming in. But let me tell you, people, artificial intelligence, the technology, precision medicine is in IVF for the last 5 years. People are using it in OBGYN now, today, whereas reproductive medicine has been ahead of the curve. It has been using it much, much ahead. And the ART law which has come in is going to bring ethical practice into it. Yes, the people who are practicing today, are going to find it difficult. It's just like the MTP law. We are going to have some problems. But believe me, by the end of a couple of years, it's going to get streamlined. ISAR is working very, very hard. We have streamlined a lot of, ironed out a lot of problems in the law. You may not be aware, I don't talk too much, but this new change which has come about, that the andrology, only MCH andrologists could do that. I have actually gone to Delhi, sat over there and got it rectified, talked to the health secretaries and actually sat with them and explained to them that the number of MCH people in our country is very less. And they have changed it. And believe me, it is a victory for the ISAR. I went there as a president of ISAR, not as an individual, but it helped and we were able to bring about, and not only can the surgeons do it, but also the MCH or the DMs or the super specialists in reproductive medicine also can perform micro TC and TC. I think that's a victory for all of us in IVF. So things are changing. The next thing that we are targeting is third-party reproduction, where it will become a little easier. And of course, people who are helping us are the people who are there in the central board. So they are our people. So there's nothing as they versus us. I think we are all together in it. And that is what is the whole thing, that we in the IVF field have to work together to be able to get things streamlined so that it becomes an ethical practice. Because of the bad practice of a few people, this law actually came in a draconian way. And it happens in every field. I think there are bad eggs in the world. 5% people are bad, but 95% people are good people. And we need to have faith in the goodness of 95% of people and proceed that way. So I think that is what IVF is all about. I'm really happy and I'm really passionate about our field and about the work that we are doing. So I'm really happy today that Oxy with Amog's Infertility Committee is celebrating World IVF Day and talking about advanced ART technology, because India today, because of the virtue of the National Registry, which already the government has set up, and we will be putting in data and we will be recognized in the world because of that. And we will make our mark on the global scene as IVF specialists. So great. Thank you, Jerani, for inviting me. But I'm sorry, I will not be able to stay back. Please excuse me because we are having a meeting here. I'm out of town and there is a meeting I have to go to. But all the best for your future. I'm sure you'll do well with your dynamism and your hard work. So thank you. And it was great meeting all my friends, all of y'all, and see you again sometime in the next meeting. I'm sure Foxy is such a vibrant, dynamic organization. We will meet again. Thank you. Thank you very much.
Thank you, madam. Thank you so much for your lovely and inspirational talk. And we really see your dynamicity as the president to look into all the difficulties what we face with the law. And we are definitely, we all work together. And it is really a good thing that we started the act, which is very important for refining ourselves and making it very comfortable. And we also look at much into the ethical practice, which is always the need of the hour. And definitely, as you say, that we'll all join together for the global research and make our fertility forum as the top in the world with all our knowledge, with all your guidance, with all the technology, everything. We will make it as a big way. Thank you for being with us in midst of your busy schedule. And we are having you again on 25th. That's the IVF day this whole week. So you will be the same way that you will be there to bless us, to guide us. Thank you so much for joining us. And we'll take your words as an inspiration and we'll work hard along with our society and all the our ISAR to work for a proper ethical practice in the IVF field. We owe it and we thank you for your guidance and presence.
Thank you.
Madam.
Thank you. Thank you.
So over to Kalyan, sir.
I'm very glad to introduce Dr. Ashwath Kumar, who is my mentor in laparoscopy. He has done diploma in advanced laparoscopy from France, endometriosis from Austria, and he has done his training from IRCAD. He's fellow of gynec oncology of GCRI, professor and Department of Gynecology, Jubilee Mission Medical College, Thrissur, Kerala, ICOG Governing Council member, IIG Managing Committee member since last 4 years, Foxy Quiz Committee Chairperson 2012 to 15, President of KFOG 2023, VP of Foxy 2019, VP of KFOG 2017, past Secretary General of KFOG. Awards he has got DC Datta Prize, CS Dawn Prize, and Rudra Sinha Prize, Best Paper, Pride of Foxy, Foxy Sun Traveling Fellowship, and He has authored 15 or more books, and he has given more than 10 orations and more than 200 faculty presentations. Over to Dr. Ashwath Kumar.
Thank you. First of all, I thank Jairani Madam and Dr. Kalyan for inviting me for such a prestigious on the special day of ART Day. Respected, we have Nandita Madam was my president when I was a vice president. So I had a lot of chance to work with her. And Pardeshi sir was my co-vice president. So we were like, sir is so senior, but we are like just friends. And Ramani Madam came after my vice presidentship, and we were too close to whatever in South, whatever activities has to be done. We coordinated in my year and Madam's year also. So they are all very close to, and Oxy is always close to me. Every year I come for Oxy. So thanks to Jairani Madam, Kundavi, Dr. Kundavi, and Priya is my student, Parashu is my student. So I'm so proud to be in between the seniors, and proud to be a part of it today. Actually, so today we have excellent. Actually, you have selected something this week. You have selected an ART is something which is, and you have very good speakers for today. And you have the very good topics like Cinderafil, which is actually close to male, as well as it's used for endometrium. Then you have then the Priya and Dr. Ramesh will be telling dialogues on choosing the best for the best success of IVF. ART pregnancy, how it is special. The Parashit tank will be coming. Then you have the one of the best panel on male infertility by Dr. Parashu. All well packed actually. So it's so nice. Anybody enters, all practical topics are there. And we know that we know Jairani Madam has made it very, and her passion for IVF, infertility, IVF, and sexual medicine, we all know. Anyway, is very hardworking, and all the best for her election. Hope that she wins and be a part. She has been working for sexual medicine for last many years, not just a person who was just for. So all the best for you for your elections, and very nice. And once more, thank all of you, man, for being a part of such stalwarts sitting in Nandita Madam, Pardeshi sir, Remini Madam, sitting along with them. If it was a stage, I would have been more proud to be among them. Now it is the webinar also. And thank you, Kalyan, my very close friend actually. So all of you, thank you once again, and thank you so much.
Thank you, sir. Thank you, sir. Thank you for your kind blessings, and thank you for your words of wisdom. And we really thank you so much for joining us, sir. And it has been a great honor for us to have you, sir. Thank you, sir.
Thank you.
I have the great pleasure and honor to welcome and introduce our guest of honor, Dr. Ramani Madam. Ramani Madam, if you say that she's a walking encyclopedia on endometriosis, Madam was the Vice President of Foxy 2020, and she has been the governing council member between 2018 and 20. And she is the International Advisory Board member for Fertility Society of Bangladesh. And she was the chairperson of Endometriosis Committee, Foxy 2014 and 16. Madam had so much awards and accolades for her. She has more than 10 gold medals in the UG and PG and 10 Foxy awards. Madam, 10 is a very big number, and we really very honored to have you here, Madam. And the Madam has made a lot of books, lot of publications, and awarded many awards. And she has been a person who can talk anything on endometriosis internationally. If you have anything to ask, she's immediately there with the answer. Over to you, Madam, to have you in between among us. We want your blessing.
Thank you, Jairani Kamraj, for your nice words. And even in the absence of Dr. Nandita, I am greatly honored to be a guest of honor along with our Nandita Madam and Dr. Ashwath Kumar, who is very close to me, and Professor Dr. Rajesh Singh Pardesi, whom I respect the most, President of MOX, and Dr. Sujata Dalvi, the Secretary, Dr. Jairani Kamaraj, and Dr. Kundavi, who is Secretary for Oxy, and Dr. Kalyan Barmude, who is the chairperson of Infertility Committee of HOMOGS, and all the faculty members, Dr. Priya Kannan, Dr. Parashuram, Dr. Ramesh, and Dr. Other persons like Chaitanya Ganapule, then Parishit Tank, Dr. Parashuram, Dr. Kedar Ganla, and all others. Please pardon if I have somebody. I know surely I have missed somebody, but still, it's it's very nice thought on behalf of Oxy to celebrate this World IVF Day. Currently, actually 2 to 3% of the conceptions are through IVF. See, once what was like etta kaniya இருந்த தாய்மை வந்து ஒரு பெண்ணுக்கு வந்து இப்போ ஒரு எளிதா கிடைக்குதுன்னா அதுக்கு வந்து IVF is the best way. See, but as Nandita madam has said, because of very few people, less than 5% of the people who are unethical, others also are suffering. But in a way, if a law has come, I think as learned persons, we all will oblige and we will have a very smooth and ethical practice in future. So the topics that has been selected today are very, very common topics, but they are the need of the day. And male infertility panel is always, I like that because we know that now the incidence of male infertility is on the high, and we have good outcome through fertility. Again, not only for people who have got OAT, but even with the obstructive or non-obstructive azoospermia, we are able to retrieve the sperms by newer techniques like micro TC and so many other things. And then we are able to have a beautiful child for the couple. So this has been a need for the current situation because so many reasons are there. The people get married late. They want to, the women especially, they want to go for a career, and divorces are more common. So they get remarried and they are in need of a child. So there are so many the indications what we thought in earlier is totally different from the current scenario. I think at this juncture, Oxy has attempted to make this wonderful IVF day celebrations with a webinar with all senior faculties and learned persons. And I wish them all a grand success, and especially to Jairani Kamraj for her success in all her future endeavors. And I pray God that she gets the best, she will reap the best fruit out of her hard work. Thank you. And I always feel that Oxy, I was a part of Oxy, because the initial part of my post-graduation, everything it was with Madras Medical College. So all the best for all the organizers of this wonderful webinar. Thank you.
Thank you, madam. Thank you, madam. Thank you so much for your lovely words and kind words, ma'am, which is always an inspiration to every Oxyan as well as a Foxian, ma'am. Thank you, ma'am.
Now I'd like to introduce somebody who is my mentor, who is the one who has brought Dr. Kalyan from a small village and brought to the Foxy platform at national level. Dr. Pardesi sir, I'm really thankful to you. He's the president of AMOGS right now and doing wonderful job. He has 28 papers presented, 21 in national and 7 in international conferences, 7-time best paper awardee in Foxy ASCOG, was Foxy faculty in AOCOG 2011 at Taipei and Bangkok, was faculty at FIGO 2006, Kuala Lumpur and FIGO 2012, Rome, Italy, was chairperson of FDA committee and vice president of Foxy 1920, and was vice president of AMOGS 2018 to 22, and now president of AMOGS 22-24. Sir, for some blessings.
Thank you, Dr. Kalyan, for kind introduction. And good evening, everybody. Respected Chief Guest, Dr. Nandita Palsetkar, Guest of Honor, Dr. Ramani Devi, and Dr. Ashwath Kumar. Dr. Ramani Devi is very close to us, and she has visited Aurangabad many times. Dr. Ashwath Kumar is our friend. With that, Dr. Jairani Kamraj, Dr. Kundavi Shankar, Dr. Sujata Dalvi, and Dr. Kalyan Baramde. Feeling proud and honored to be a part of this program jointly with Oxy. I wish to express my sincere thanks to Dr. Jairani Kamraj and Dr. Kundavi Shankar for joining hands with AMOGS for Women's Health. I wish to congratulate Dr. Jayarani Kamraj and Dr. Kalyan Baramde, conveners of this program, for organizing such an academic webinar in advances in ART. And with the galaxy of speakers already told by others, chairpersons, panelists, I think this will be a great program. To some highlight to Dr. Jayarani Kamraj biodata, I think she is a president of Oxy, and she was Assistant Secretary of World Health Organization of Sexual Health. I think this biodata, so I wish every success to Dr. Jayarani for her future endeavoring chairperson of Sexual Health Committee. I think she will be the right person for this post. Wishing every success to this webinar. Thank you. Thank you so much for inviting me. Thank you.
Thank you, sir. Thank you so much for blessing us, blessing me. And I thank you very wholeheartedly for being with us and being a great support. And I really have to thank Kalyan sir to join with us for this wonderful 1 week celebration of IVF Day. So fertility is it is very close to my heart as well as close to you all. And in that way, I'm very thankful for you for being with us and blessing us and giving all your support, sir. Thank you so much, sir. So over to Mohana. I think we'll be starting the scientific session. Mohana, can I have the chairpersons first? Yeah. So I have the great pleasure and honor to welcome the chairperson of the first session, Dr. Mandar Karambelkar, who is the secretary of the Chalisgan OBGYN Society. He is the consultant at the Shalia Shobha IVF Hospital, Chalisgan District, Jalagan. We welcome you, sir. And I have the great pleasure and honor to welcome Dr. Manisha Vazade, who is the secretary of the Chandrapur OBGYN Society, who is the past secretary of the WDV Chandrapur, and past treasurer and the joint secretary of Cox, and life member of the PCOS Society of India, and her special interest is in the women's health and care. Over to you, chairpersons, to start the first session of this webinar of Advanced in the ART.
Good evening, everyone. Myself, Dr. Manisha Vasade, Secretary OBGY Society. First of all, I would like to thank the organizers, Dr. Jayarani Madam, for giving me this opportunity as to be as a chairperson for this session. Thank you so much, Madam. I would like to introduce our speaker for today, Dr. Kalyan Barmade, sir. He is a consultant, infertility and gynecologist, director of Barmade Hospital, Latur. Chairperson, Public Awareness Committee, Foxy.
I think Dr. Kedar CV, please.
Yeah,
So Dr. Kedar, yeah.
Sir is the, yeah. So, yes, sorry.
Dr. Kedar.
Dr. Chitra, it is Kedar.
Dr. Kedar.
Chitra.
Okay.
We want a CV of Dr. Kedar.
Kanla, yeah. So I'll say it.
Dr. Kedar, sir. I'd like to introduce Dr. Kedar Gandla. He's a past secretary of ISAR. He's a past secretary of AMOGS, and now he's a secretary general of Maharashtra state of ISAR. I welcome Dr. Kedar Gandla, who is so well versed with infertility practices, and he is the one who is doing IVF in almost every district of Maharashtra. So I welcome Dr. Kedar Gandla, sir. Can you share the screen, sir? Dr. Kedar had just joined. No?
Yeah, he was there only, sir. Kedar Gandla, sir.
speaking to someone else. You can wait or call again.
I think Dr. Kedar has just left out with some technical glitch, maybe.
I have come. I have come.
Yes, Dr. Kedar, sir, please. Can you share the screen, please?
Host has stopped my video.
Chitrakala, can you please attend, sir?
Chitrakala, can you make him
Yes.
co-host?
Host
Start
button.
my video.
Yeah.
Yes, sir.
Okay, I'm on. Terminate. I have to start now, or
Please, sir. Please
Yes,
share your screen, sir.
okay. Okay. Thank you very much for. Am I audible for everyone?
Yes, sir. Yes, sir. Yes, sir.
Okay, so now the subject which I'm going to talk about is little unknown for everyone. And this is the talk which I gave 4 days ago. So it's about use of sildenafil citrate in OBGYN. Okay, so it's going to be little witty. So everybody try and understand. So basically the irony of the drug is that the drug was meant to be for angina, and they started seeing erectile or penile erection in older age group patients. And that's how the Pfizer realized the drug's potential, and it was approved for erectile dysfunction in 1998. So thereafter, the sales of Viagra has been going on booming. The male infertility, it can be used for two things: erectile dysfunction and sperm motility. So importance is generally seen in the elderly age group, but in our infertility age group, because of anxiety and stress, sometimes there can be a pressure for performance, and that sometimes leads to not producing a sample. So sildenafil citrate is a specific enzyme inhibitor of cyclic GMP, which causes increased release of nitric oxide, which acts on the smooth muscle relaxation. Now, these smooth muscle can be in the penis or the corpus cavernosa, or the uterine blood flow, or the uteroplacental blood flow. So basically, this particular paper talked about whether this nitrogen oxide synthetase and inducible nitrogen oxide synthetase isomers are whether they are identified in the vasculature of the endothelium of human endometrium and the blood vessel. So it has been identified. So these are the way babies are produced during corona time, and this is the way the future will be formed. So this is basically a lifestyle drug, because they have to perform on a particular day, which causes a lot of pressure in the male. Now let's go to some other slides. So we know that erectile dysfunction can affect a lot of marriages, and Viagra, which is known as sildenafil citrate, helps in improving the outcome. The only problem is headache and bluish discoloration of the eyes, except the older age group patients. If they take it, then there could be issue of heart problem. Should be taken 1 hour prior to the activity, and it remains inactive in the blood for 4 hours. The initial dose is 50 milligram in a young patient. Geriatric, let's start with 25 milligram 1 hour. Now, sperm motility, this particular study talked about giving oral sildenafil citrate single dose 50 milligram, randomized crossover trial. Sample was collected 1 and 2 hours later. And what they found that there was an improvement in the semen motility from 28% to 37%. So this itself helps in identifying or increasing the motility, especially when you are facing a problem with astenospermia or severe oats, and your embryologist wants more motile sperms. And this is the technique by which you can increase the sperm. Now, systemic meta-analysis suggests that 1 hour prior, when you give sildenafil citrate, it increases the motile spermatozoa, rapid progressive motility increase. But very interestingly, these changes are only seen in infertile men, but not in normal person. So the rest patient should not be worried about. And another paper which is very clearly showing increase in the sperm motility, and grade A, grade B, and especially grade A and grade B, which is statistically significant with a good amount of recovery of a motile sperm. So with this, we'll come to thin endometrium. Thin endometrium is defined as endometrium less than 7 millimeter on the day of the ovulation in a natural cycle, or on the day of SCG in a GnRS stimulated cycle, or when you are going to start progesterone from the day of the frozen thaw cycle. So there are 3 types of endometrium. The first one on the top is the triple line typically wanted endometrium for a good outcome. B, isoechogenic endometrium, where the pattern is not good. And third one is homogeneous, like secretory endometrium seen in proliferative phase of the cycle. So what I'm going to discuss is about this top one, where the triple line endometrium is the what is seen. This is the endometrial blood flow in a patient who was on gonadotropin stimulation. You see the blood flow is not adequate, especially in the luteal phase. When you give 25 milligrams 3 times a day, you see the blood flow improving to the endometrium, which will help in implantation. So then another patient, another woman treated with normal ovarian function with 2 consecutive prior IVF failures. Okay. Now, in this, the endometrium was not adequate, treated with sildenafil citrate, and you see there is increase in the endometrial thickness and also ongoing pregnancy rate. Now, let's compare vitamin E, L-arginine, sildenafil citrate, and control with the history of ET less than 8 millimeter, and uterine artery resistance was also noted. What you see is sildenafil citrate had a high, the improvement in the RI was good, and improvement in the endometrial thickness was also good in the sildenafil group, and with a good amount of pregnancy rate. Now, meta-analysis of sildenafil citrate suggests that in infertile women with thin endometrium, it says that this was done by 2 independent literature search. Now, if you see here, the various dosages were 25 milligram 4 times a day with ethinyl estradiol. Another is 50 milligrams a day with ethinyl estradiol. Another 100 milligram with without ethinyl estradiol, that went in ART, and in IUI cycle 25 milligram 6 hours. Again, so in IUI cycles also it has been used, in clomiphene cycle also it's been used, and in last one in FAT cycle it has been used. So what they found that the radial artery resistance significantly lowered. So there was resistance fall with increased pregnancy rate and a biochemical rate in sildenafil group. So found to be very effective in improving the endometrial thickness and the biochemical pregnancy rate. Now, late onset IUGR, and oligohydramnios. So late onset IUGR generally starts after 22 weeks, where it is the second and third trimester issues where the nutrient going across the placenta through the uteroplacental blood flow. And maybe there is a constriction in the endomyometrial junction, which reduces the blood flow. And the impact of that is seen in the umbilical artery and fetal circulation. So if you give sildenafil citrate, it will cause a vasodilatation of both the uterine artery, leading to increased blood flow to the placenta, which will lead to increased blood flow to the baby's kidney and improve the AFI. So this paper particularly wanted to find out whether phosphodiesterase 5 inhibitor is present in the human chorionic artery. And this is an animal study, ex-human plate was created and arterial rings were created. And what they found, with increasing concentration of sildenafil, there was a progressive relaxation of the arteries in the placental circulation. So we have proven that there is this enzyme and which can be blocked, and you can achieve dilatation of the placental rings. This is a preclinical study. Now, preclinical study, if you see, it's done in rats, ovines, rabbits, mice, and lamb, and all this where artificially growth retardation was created, and then sildenafil was given, which shows increased weight gain, increased pregnancy outcome, and helpful in IUGR. Now, again, another systemic meta-analysis, and this is for 24 to 34 weeks. Now, ladies and gentlemen, I want you to just pay a little more attention at this point. This study demonstrates improvement in the pregnancy outcome with women with IUGR. It helps in improving the birth weight and prolongs the pregnancy, which is very important. But it did not positively correlate with stillbirths, neonatal death, and NICU admission. It does not say about the number of days stayed in NICU. Now, in this particular paper, if you see, again, 25 milligram 3 times a day, or 50 milligram single dose, or 25 milligram 3 times a day vaginally, or 25 milligram daily. And if you see 24 weeks, 24 weeks, 24 weeks, fourth one is 28 weeks and above gestation. And that is has the least number, 40. And then comes again 22 weeks and above. Again, if you see 25 milligram 3 times a week, 20 milligrams, 50 milligram 8 hourly. Again, 20 weeks onwards, 22 weeks onwards, 24 weeks onwards. So if you look at the chart, which clearly shows about the neonatal growth and the neonatal weight gain and gestational age at delivery, both favor sildenafil citrate. So by giving this, you are not only increasing the weight of the baby, but you are also increasing the gestational age of the delivery. Means if you have an IUGR diagnosed at 30 weeks with increased resistance in the umbilical artery, okay, you start sildenafil citrate, it may not improve, but it will be maintained at this level. Fetal growth will happen, and you will be able to tie it up for next 5 weeks, and the maturity will be achieved. If you look at the stillbirth rate, neonatal death, and NICU admission, it seems to be in favor of control, or there is no conclusion formed. I would like to say that in India, where is a developing country, I think we should consider any baby for IUGR at 28 weeks and above a salvageable baby. Below that, if the parents are very rich, and they can afford the NICU, to put a baby at 26 weeks IUGR to pay 15 lakh rupees, I think it's a matter of debate. So I would personally feel 28 weeks is something very good. So pregnancy, this is a category B drug. This has been used in patients with primary pulmonary hypertension. They conceived on this drug, they continued the pregnancy and delivered the baby. Many babies are formed. The drug seems to have no teratogenic effect or embryotoxic effect or phytotoxic effect. Now, this is our study where a case was happened at about FGR at 26 weeks, and we gave her sildenafil citrate with fetal growth restriction. As you can see, the Doppler parameters improve and uteroplacental circulation shows improved parameters. There's another study. This is a very interesting study. This is my own staff. At 21 weeks, there was uterine artery resistance. Then we gave her L-arginine, and 4 weeks later, we found that there was IUGR with intrauterine growth retardation. So around 24, 25 weeks. We started around sildenafil citrate, and at 30 weeks, there was absent end diastolic flow. This flow was maintained, and USG Doppler showed brain sparing at the MCA in 30 weeks of Doppler. So this is the growth chart of the baby. You see ultrasound done almost every weekly, and she developed hypertension later on. That also was treated. And you see the weight gain of the baby. Ultimately, baby was delivered at 2.2 kilos with cesarean section. But because of growth retardation, the baby was admitted in ICU for 2 days and then out. So basically, it improves the uteroplacental circulation and improves oxygenation and nutrients to the fetus. This helps in temporarily for 4 weeks or 5 weeks, going to the increasing growth of the baby, increasing the maturity of the baby, reducing the time spent by the baby in neonatal care and fetal morbidity. So this is what I want to say. So 25 milligrams 3 times a day vaginally. Now, another interesting case is a case of torsion we had. We were waiting for anesthetist and surgeon to come, and I had read about an article about a scrotal torsion was treated with a sildenafil citrate. This is completely thinking out of the box. And this is the blood flow after sildenafil citrate. Now, this thinking out of the box is basically when the torsion happens, the ischemic area in the ovary produces a lot of ROS. Now, when you detort, the reperfusion which happens, which causes actually damage to the ovary, which is called as a reperfusion injury, that can be prevented by giving sildenafil citrate. This case has been published in the journal. So this is how the baby looks. And this is how the Viagra sales go. Thank you very much, Dr. Kalyan Baramde, for giving me this opportunity to share my opinion on this subject. Thank you so much. Thank you for inviting me.
Thank you, Dr. Kedar sir, for this innovative talk on a drug which is thought primarily to be used only in ART or IVF, which you are using in day-to-day obstetric practice with such good results. So my one question to you, sir, in cases of improving the endometrial Doppler, when you use sildenafil, once patient conceives, when to stop this drug?
See, since the drug has no teratogenic effect, you can continue till 6 to 7 weeks. Let the fetal placenta take over and then stop. It should not be a problem. It just improves the vascularity.
Okay, because today I got one patient who is conceived 6 weeks, twins. She has come with spotting PV. Because this drug to be used per vaginally, so I was just skeptical about how to go about it.
Now when that happens, then we can shift to orally. But you know, the culprit of early pregnancy bleeding is echospray. It's not even heparin, it is echospray. So normally nowadays, what we do is, moment we see the cardiac activity at 6.5 weeks, we stop the echosprin, continue the heparin, and restart echosprin at 9 and 9.5 weeks. So this way we are trying to control, because n number of time patients will complain about the spotting and the bleeding or subchorionic clots formation.
Thank you so much for this insight.
I want to ask one question.
Yes.
Which route is more preferred? I mean, vaginal route is more preferred or more effective, or oral route is more effective?
Madam,
In
in man, when they take 50 milligrams of sildenafil citrate, generally complaints of headache and blushing and bluish discoloration of the eyes. I have given 25 milligram orally in ladies 3 times a day, and I have not seen any side effect. But as micronized progesterone, sustained release oral versus vaginal, what do you prefer?
vaginal.
Simple answer. The drug delivery is so easy. There is no wastage of drug, and it improves the blood flow. So I also do one thing with vaginal sildenafil. I dip in the water and give vaginal progesterone, so that it helps in dissolving the tablet. Otherwise, the vagina, if it's dry, it will not get dissolved. So that is a trick to be played.
Thank you, sir.
Dr. Manisha, your concluding remarks, please.
So thank you so much, sir, for such a wonderful and informative talk on the much less talked sildenafil citrate, and we got to know many other uses of sildenafil as well. So thank you so much for such an informative talk.
It was surprised that I received a call from Jairani Kamlaraj. Thank you so much for your call, because I was about to call Kalyan Dharam and ask him, is the talk today or tomorrow? Thank you so much.
Thank you
for the
joining us.
thank you for the
start seeing the group,
giving all your
sir.
valuable things about the sildenafil, which we thought was for the men. Now it's almost a blessing for most of the women, the fertility. And definitely, as you rightly pointed out, sildenafil has a very good effect on the endometrium, especially in an ideal cases. And we usually stop when the pregnancy is confirmed, but we haven't continued the drug once the pregnancy is positive. Probably your, your data and the research, what you have put into it, may throw us a light. Because we usually stop when we started the HIV, stop it at the time of once the pregnancy is confirmed. Probably we can look into continuing it, which may be a little helpful.
Madam, you try in astenodospermic patient 1 hour prior, when you are freezing the sample. Try that way, you will see improvement in the motility. So your embryologist, the Priya, will be very happy that you have, instead of giving 2 sperm which are running around, now there are 20. So she is little more relaxed.
What's the dose, Kedar?
25 milligram for sperm motility, 50 milligram 1 shot 2 hours prior.
So, Kedar sir, when you stop sildenafil after the conception?
Around 6-7 weeks, like how we taper estrogen and everything, we taper it off. Okay.
Thank you so much.
Thank you.
Doctor with stethoscope. I thought he will be carrying an embryoscope.
Yeah.
I wish I could carry embryoscopes and have as much as we have a stethoscope.
That's really great.
Yes, please. So I'm really happy to. Anybody's introducing, or should I?
Anisha ma'am, you make it only introduce.
May I introduce?
Yeah, ma'am, please, ma'am.
Yeah. Okay, so our next speaker is Dr. Priya Kannan. She's MBBS, MD, MC. She's a director, clinical embryology, Garbha by Fertility Center. She's a past president of AC India. She's joint secretary IFS Tamil Nadu. She has authored chapters in books. She has presented lots of papers in national and international conferences. So over to you, ma'am.
And Dr. Ramesh as well, because we'll be having a dialogue now.
Okay, next speaker is Dr. Ramesh Raja. He's MBBS Diploma in Clinical Embryology. He's a fellow clinical andrology and also fellow sexual medicine. He's a senior clinical embryologist and andrologist. He's the first Indian to receive proficiency in ICSI issued by American College of Embryology in 2015. His area of interest is quality control in IVF lab, sperm DNA fragmentation. He has published papers in national and international journals. Sir, over to you, sir.
Thank you, ma'am.
Can I share the PPT or Ramesh will be sharing?
You can share the PPT.
Okay. I'm just trying to share. Yeah, just a second.
No issues. Yes, ma'am. We can see
Yes,
the screen, ma'am.
Yeah, yeah. So,
okay.
Madam had given us a very interesting topic, choosing the best for the best success in ICSI. So we'd be going through a few, parameters that we thought is quite important for this. As we know, the first thing that we would start is with the egg, because that's the first thing that comes to us. And so, Ramesh, can you tell me what are all the parameters that you look at for an egg when it comes for ICSI? What are the important parameters that you would like to look at?
As an embryologist, when we receive the oocyte as a cumulus complex, we actually think over from the cumulus complex as it is, how it is expanded, whether it is of matured one or the immature one, slightly from the cumulus complex itself. So usually there will be three things will be there. You can see the picture now. One will be the expanded cumulus complex, which is usually will be the mature oocytes. And you can if you focus it properly, you can able to see the first polar body. And here you can see at the 1 o'clock position. The second picture will be like the little unexpanded or compact cumulus complex, which usually the immature denotes the immature oocytes. And third and fourth picture will be the very expanded cumulus will be there. Sometimes it will be dark in color or it will be dark clumps. These are the usually hyper mature oocytes. From these also we will be getting pregnancies, but there are less likely the chances of getting pregnant. These are the few morphological of the cumulus complex we can see from the oocytes now. And
what do you think about the as a cumulus? What do you think does it have a positive correlation to pregnancy rates and implantation? Or is there anything
actually
that
initially
in the
we thought the
presence
cumulus complex
such as blood clots, do you think it has got an adverse effects on the oocytes?
Correct. As such, cumulus complex, the positive correlation is lesser, but if it is associated with the blood clots, definitely it impacts the factor, because the blood clotting factor 6, which is important for the other things like fertilization, which will be reducing the fertilization cleavage and other things. Definitely there will be adverse effects if you have a blood clots with the cumulus complex.
So what exactly do you do
these
when
are different
you have
regulators or genes?
So what exactly do you do practically
when you have
when you have these cumulus with blood clots?
Practically what will happen is it will be very sticky to differentiate between, it will be to separate between the blood clot and the thing. Half of the time, we need to bring in a needle to separate the cumulus and also the blood clot. Then after that, immediately wash it completely with the HT solution, whichever is there, your biological solution. Completely make sure there is no blood in the cumulus complex and put it in the animal side tissue.
So right.
Okay.
So moving on to the zona pellucida, there are a few important things that we do look at the zona pellucida. No, Ramesh, but
yes,
unfortunately, without the technology such as a pole scope or something, or having the laser, it's quite difficult to differentiate between the zona pellucida. But one of the few important things that we always note is like, these abnormal zona and the ovoid zona and stuff like that. The thickness, of course, you can measure only when we have laser, or because otherwise our subjective visualization is not appropriate. Birefringent, of course, you need technology for that. But somehow or other, the evidence has not been very great about having any difference in this. So as such, having an elongated zona or an abnormal zona has not shown to have much of difference in pregnancy rates, no, Ramesh. Even with the Vienna consensus and everything, the Istanbul consensus also did not show much of difference.
Yes, that is true, ma'am.
Do you think?
One point I need to add is sometimes sometimes what will happen is if you compare with the sibling oocyte, sometimes few oocytes will have a thick zona, like a partially thick zona. So what this will happen is people say that if you're transferring on day 3, these zonas may require the assisted hatching. But if you wait and see till day 5, the assisted hatching, usually the thinning will happen and easily it will come out. So initially it was believed that this thick zona after thawing from the cryopreservation will affect the implantation potential. But nowadays, I don't think so. This come to the picture for the success.
Oh, that's great. That's very good point that you have brought about. Do you think we should look for meiotic spindles? I mean, you should invest in a polescope to look for meiotic spindles to separate the good quality oocytes from the not so good quality oocytes?
Yes, so actually, initially, when I started my career 10 years before, they say that meiotic spindle is very much important. But after I think people have studied so much, and if you, like keeping in the 12 o'clock or the 6 o'clock push of the polar body itself will have it. There is no, you won't be able to damage the meiotic spindle in that. One thing. Second thing is polescope came in a bigger way, but nowadays I don't think the polescope is useful for doing the XC procedure as such.
Yeah, there are so many parameters that has been studied in the spindle, such as such seeing the spindle to the length, the alignment, location, retardance, density, birefringence, everything. But unfortunately, nothing much. I mean, practically, we are not able to apply these in our practice. But one thing that is very important that we notice is the polar body. Of course, the presence of the first polar body is primary for us to go ahead and do the ICSI. Are there other types of polar body which you would think to deselect the oocytes, Ramesh?
Yes, sometimes it will be more than one polar body. If you can even see 3 or 4 polar body, like multiple polar bodies will be there, or the giant polar body, like a bigger polar body will be there. In those cases, we really know whether the chromosome has been properly, like N has been differentiated. This could be one of the reasons. Maybe if you don't want to inject it, better to don't want to inject, because sometimes it will become like a good blasphemous also. But we don't know the abnormality just there, because as we do in ICSI, is the mechanical effect can improve, but usually we don't select this type of, yes, ma'am, it can activate.
Yeah. Yeah. So when we have multiple polar bodies, or definitely when there is one abnormal polar body, we generally don't ICSI them. Even if somebody ICSIs them, it should be cultured separately just to know, because it should be differentiated. It could be an abnormal embryo, and that means aneuploid embryo, and hence we generally do not recommend to use those oocytes. And you notice in various patients about the perivitline space. Some have large spaces, some have small spaces, some have a lot of inclusion bodies, or and those things in the perivitline space. Do you think they are significant for the selection of the oocytes?
Usually, this perivitline space, people say that the pathology is one could be because of the higher choroidal use, or even the oocyte morphology because of the highest, if you expose it to highest. But we really don't know what is the exact pathology, but definitely there are more debris, like dark debris in the PVS. And if it is a bigger PVS space, definitely will have an effect on the other things, like the fertilization, cleavage, and the implantation potential of an embryo.
One thing I generally notice in these things with the large perivitline spaces, for us to inject, we'll be holding the zona. But then when you inject it, the needle goes in, and then the denaturation rate will be, and the ooplasm can move inside the zona,
Correct.
And hence
Correct.
you
Ma'am.
might
Correct.
have to prick more than once, and the denaturation rate can be slightly higher in this. Have you noticed that as well?
Why higher interest? Correct.
Yes.
Yes, ma'am. As I have noticed it actually.
So, and the next one is people have looked at shape. Do you think that has got the morphological defect in the
Yes.
shape has got
Because
anything to do?
actually, this I feel is if one follicle is which is stuck between the other follicles, because of the follicular growth, this shape also grows like that. I have seen these kind of oocytes which is developed in a good embryo. When the blastocyst comes from, slowly it will get expanded, but this will hatch soon when compared to the other things. So I don't think so. This will have an impact on the other like fertilization and also
Yes,
the
true.
growing
That is what the
potential of an
consensus
embryo.
also says. But something we definitely do not use is a giant oocyte, obviously, because it's a
Correct, ma'am.
tetraploid oocyte. So
Yes,
we
ma'am.
definitely never use a giant oocyte. Here in this oocyte, you can see 2 GVs already.
Journal
How do you,
oocyte.
I mean, how we look at the giant oocyte, it's like double the size. Like in this lower picture, we can see the normal oocyte as compared to the giant oocyte. So a giant oocyte is a tetraploid oocyte, and hence we definitely do not use it. How, is that how you see it as well?
Yes, ma'am. Same thing, ma'am. We don't even inject it. We just kept it in there. That's all. We usually discard it.
Absolutely, yeah. So in the cytoplasmic changes, these are all the listed changes that we have. We, as we are finicky and we keep noting all these things from vacuoles to clustering SCRs. Of these, which you think are actually, does have some effect on the implantation rate or the pregnancy rate when we do
Yes, ma'am.
ICSI?
First will be the SCR, ma'am. If there is a clustering of the smooth endoplasmic clump. Second will be the vacuoles. And third will be the central picking. That will be more central granulation. These will actually affect the fertilization potential, and also it will affect the cleavage rate and also the blastocyst rate. Even the miscarriage rate is higher when compared to the other oocytes. This has been observed clearly. So this is the granulation picture which we show.
It was as such mentioned in the Istanbul consensus that if there is a SCR in some of the oocytes, then the cohort itself could have an issue, and the SCR oocytes should not be inseminated. They had even given a recommendation to that level. But then granulation, this is how the granulation looks like. So if it is as severe as this, then it can affect from oocyte cryosurvival to compromise nuclear morphology, to decrease in blastocyst rate, to decrease in pregnancy rate as well. And
in this vacuole and SCR, ma'am, it will be very difficult to inject the sperm also. We should not disturb both the things. So either we need to go a little bit above the SCR, it may affect the amniotic spindle, or even if you go a little below, the fertilization won't get happen properly. The PN will be at the periphery, and the cleavage rate will be in an abnormal way.
Absolutely, that's a very practical tip to take home, because when we are injecting the vacuoles, we can activate the apoptotic mechanism. So we can it can lyse the eggs a lot, and SCRs as well. It will be we want to actually avoid the SCR or the vacuole when we are doing the ICSI. When cytoplasmic viscosity is, when we are withdrawing, we see that funnel that causes cytoplasmic viscosity. It was mentioned as one of the characters of a good character of a oocyte, but unfortunately there was not much of evidence on that. So I think these are the basic features on which we can say these are good oocytes and these are not so good oocytes. Absolutely, the ones for us to deselect oocytes is one, the presence of a accumulation of smooth endoplasmic reticulum, large vacuoles, a refractal body, and dark clusters meaning a large amount of granularity, and of course a giant oocyte and a large polar body. Have I summed up well, Ramesh?
Yes, ma'am. Yes, ma'am.
Yeah.
Definitely.
So these are the points to deselect the oocyte when we are looking for ICSI. Why we are saying in ICSI? Because all these characteristics we'll be able to see only when we denude the oocytes. Otherwise, we will not be able to denude the oocytes. So this is exactly what we are looking for. As Ramesh has beautifully mentioned, a fluffy cumulus, nuclearly mature egg,
Actually, initially we were doing the swim up, but can you hear me?
Yes, we can hear you now.
Okay. Initially, like evidence-based says that density gradient is little, I mean, they give you a good DNA fragment. I mean, it's a good morphologically sperms, which is yielded because of the double gradient. So we usually started doing this double density gradient prepared. Give you a good thing. The only thing is once you process the sample, you should make sure you shouldn't touch the semen to aspirate the post wash. So density gradient actually we prefer to do it now.
Okay, that's right. I'm a swim up person. I prefer to have a neat, clean sample using swim up. I said, don't complicate things. Just put that media in there and then take it out and just take the top 2.5 microliters or something and give it to me. That's exactly how I like my thing. I'm sure you will also remember Pandian sir saying that yes, you will see agglutination only when there are lots of sperms.
Correct. True.
Correct. So that's something very difficult to, when it's something like this, it's very difficult to pick up sperms for ICSI, or, we just end up picking whatever comes out of it rather. So how do you go about, can you tell us, how do you go about when there is absolutely no motility in the sample that's given to you for ICSI? Okay, let me go ahead and say, when there is a sample that is got absolutely given. I think Ramesh is having some technical glitch. So when the sample is given and we know that the sample has got a motility, less motility, we'd like to keep the sample at 37 degrees so that it can improve the mobilization at that some point. If we already know that the patient has got very poor motility, it would be a good indicator to do a trial preparation much before the patient goes in for ICSI, so that we know that if we prepare the sample, does the sperm start moving or something? And also use theophylline during the preparation to see if that can improve the motility in a sample. Even after that, if all the sperms are not viable, TESE is another option that we have. But of course, we'll have to counsel the patient that there is no guarantee of retrieving any motile sample or any viable sperm for ICSI, even when we are doing TESE. But when we are given a sample, before we give that, we have 4 other methods using which we try to make the sperm move. The one is a mechanical touch technique. We touch the sperm and see if it moves, then that's like a live sperm. It may not be motile, move from one place to another, but it twitches when we are touching using the injection needle. Then that is one. Of course, the Haas test is there. We have been using theophylline quite routinely nowadays. And of course, you can use a laser-assisted immotile sperm selection, where if you do the laser on the tail and it curls, then that means it is a live sperm. Ramesh, are you back? Okay. So that is what we do when we have absolutely more immotile sperms with us. Ramesh, can you tell me how you would like to prepare the sample when you have low or extremely low count in your extremely occasional sperms?
Yes, usually what we do is we go for a pellet and swim up, take the pellet and put it in the PVP and see. Sometimes what will happen is there's it's a low count, the preparation is much more important than the other things. Sometimes if you don't, even if a density gradient also will gather the good number of motile sperms and give you the post-wash, and you can start using the eggs.
That's right. So sometimes you might have to go right, do the swim up and then go right to the pellet, take the pellet and then put it in the PVP and use it. There you would have non-motile, motile, a lot of debris. It will be very sticky, but those are the options that we have to exhaust before saying that we are not able to get any sperms for the ICSI. And in TESE samples, do you have any preferential method to prepare the TESE samples for ICSI, Ramesh?
No, actually, initially, I mean, TESE sample, if it is not mixed up with blood, it will be easy to prepare them. Like you can put a density or even a pellet and swim up and you can take this in. Only there is full of RBCs are there. Then you need to, I think, you need to prepare the sample in the way that you need to dehydrate it. Then you can prepare the sample and go for ICSI. But again, the TESE sample, people thought that when to do the TESE before the ICSI, that is the one thing, ma'am. But 2 to 3 hours we have started doing for the TESE sample. That is also going good. Suppose in case if patient is having a little higher on the FSH side, and if you do on the day before also, you have tried it. But 3 to 4 hours before ICSI, we can able to pick up the spermatozoa is now what we are doing.
Yeah, so it gives the sperm to at least start moving and coming out of the sample, and that way you will be able to find a little bit. So in cryothawed epididymal and testicular samples, how would you like to prepare? Do you like to thaw them on the day of ICSI or the previous day? What is the maximum number of hours you would like to keep them out?
Usually, cryothawed sample will be very sticky when compared to the fresh sample. Usually, I used to prefer 3 to 4 hours before that. But the thing is, you can nowadays it's like easy, like sperm motility enhancers are there, so we can use it up and pick up the good motile spermatozoa, which is morphologically normal.
Thank you. So I guess those are all the special situations, and for the conventional selection of the sperms, we do have newer methods of sperm selection. Can you, due to, I think we are going ahead with time, so can you give a gist of what practically, is there anything that we can take? Because the Cochrane does not give a major go ahead, or with the studies available, they have not shown any improvement in the pregnancy rates, birth rates or pregnancy rates. Is there 1 or 2 lines that you would like to mention about this, Ramesh?
Yes, ma'am. There are so many things like MAGs and all come up, like magnetic activation. But only thing is what we are practically doing is the simple thing. One will be the pixie dish. That will be easy to find out the hydrogen base. Second will be the IMC. But if people say that ICSI and IMC, once you start doing, it will be easy for you. And third will be the microfluidics. Now it will little bit of taking up. So microfluidics is giving you a good results nowadays. The 2 things, IMC, pixie, and the microfluidics I started doing.
Yes. And there was also in Cochrane, it was mentioned that in the 2019 Cochrane, that when you use the pixie, though it may not improve the pregnancy rate, it can probably slightly reduce the miscarriage rates. So that is what was given. So yes, microfluidics is picking up because it does not involve a lot of investment on the equipment or anything, but it is just very easy to perform as well, and we are able to see. But unfortunately, with the countless methods we have, none have shown to have a great quality or results in improving pregnancy rates. It finally bogs down to the conventional preparation of the semen sample and the operator, who is the embryologist, picking up the sperm, isn't it?
Yes, ma'am. True, ma'am.
Yeah, that is what finally it comes down on us and our patients. So if that is the case, how do we so which means that it is not just the egg and the sperm, it is also the operator on the lab, which is important to have the best results in ICSI. So what are the options? What is your suggestions on that?
Yes, I'm actually handling the male and female gametes. More than that, we need to have a quality assurance in our IVF lab, which will help in improving all the parameters. Like this quality assurance, which includes the quality control and teaching the personnel. I mean, the persons who is the colleagues who is associated with you know to the proper subject, so that they will help you in bringing up the quality control each and everything, right from the scratch till the everything like embryo eating. So we need to have a quality assurance in IVF lab, which will be the like the backbone of the success of the IVF lab.
Yeah, thank you. So I think the one thing that we should always see is it is not just the egg and the sperm. For example, when somebody has got a FERT failure, it is also we should look at what was happening in our lab, and the operator, the embryologist side also should be looked at in terms of when we have a trouble. So when we're having troubleshooting, we should understand the physiology, we should prepare for troubleshooting, and which can happen only when we have the SOPs in our hand. So, so all this is to make it safe and healthy, for a safe and healthy child to be born, to select the best of eggs, best of sperms, and give it a safe environment for a safe healthy child to be born. And thank you, madam, for this very nice opportunity for myself, Ramesh, to bring out the factors that can give the best of success in ICSI.
My sincere thanks to Dr. Jainani Kamaraj madam and Priya Kannan ma'am. Thank you so much.
Thank you, Priya. Thank you for this very nice and very interesting part, which never we look into it and throwing a lot of light to us about ICSI. And thank you so much, Ramesh, for being with us.
Thank you.
Madam,
Thank you, madam. Thank you for the opportunity, madam.
It's a pleasure. Manisha, madam, anything you want to conclude? Yeah. I think we're moving on to the next second session. Can I have the CV of the chairperson? I have the great pleasure and honor to introduce Madam Dr. Nandita Chauhan, madam, who is the president of MOX. Madam is a dynamic person, well known for her academic expert. She is the considered gynecologist obstetrician from Psychiatric Hospital, Mumbai. And madam is well known for her expertise in histoscopy and the cases with endometritis, adenomyosis, and menopause. And madam is well known for many of her publications. Can I have the next slide? Welcome you, madam, to chair the second session. I have the great pleasure and honor to introduce Dr. Anil Gopinath Bandre, sir, who is the president of Ahmednagar Obituary Society. He is a consultant of the Bandre Hospital, a laparoscopic surgery center in Ahmednagar. Over to you, chairperson, for the second session. Sir, is the chairpersons are there? Kalyan, sir? So I think I'll introduce Dr. Parishad Sang, sir, who is the president, who is the treasurer of POXI, and who is the chairperson of the Second Motherhood Committee between 2014 and 17. Sir is the consultant of Ashwini Maternity Surgical Hospital, a center for endoscopy and assisted reproduction, Mumbai, and he is the consultant of the Jupiter Hospital, Thane, and he's the honorary professor of the Pacific Medical College, Udaipur, and consultant for ART centers, more than 16 centers. Really amazing, sir, how you manage 16 centers as a consultant. And he has a lot of awards and publications. He has the Bhaskara Gold Medal for first place at Tikanvi and Kamindao Yuva Foxy Orator Award in 2011 and 12. And he has appeared 100 review publications in index journals, and he has published many publications in the CME publications and textbooks, co-authored 4 books in OBGYN, and he has been in the editorial board of food index journals. Over to you, thanks, sir, for your talk on ART pregnancy. Sir has joined the answer. I tried calling him. Mohana, we'll start the panel. I think sir is held in an emergency, I can believe. So we'll start with the panel and we'll keep going. If sir joins, we'll have it as his talk at the last. You can introduce Parsha. Unmute yourself, Mona.
I welcome Dr. Parasuram Gopinath to moderate the panel. This panel is on male infertility. Dr. Parasuram Gopinath is a medical director, Simar Cochin, a unit of Edappa Hospitals Private Limited, Kochi, Kerala. He is a scientific director, Simar Fertility Centers, Kochi, Thrissur, and Coimbatore. Sir is a teaching faculty in Edappa Hospitals Private Limited. I welcome Dr. Parasuram sir for an interesting panel on male infertility. Sir, I would can you introduce your panel and start the panel, sir?
Thank you so much, but I think I don't have the. Okay, yeah, all right.
Okay.
Yeah, I think you can do the honors. I think you can just introduce.
Yeah, sure. The panelists are Dr. Aparna Rahul, MSDNB. She is president of Aurangabad OB-GYN Society. Yes. Then Dr. Chaitanya Ganapule. Sir is the treasurer POGS, chairperson Midlife Committee. He is a national coordinator Endocrinology Committee FOGSI. Dr. Kanjan Duruggar. Dr. Rajesh P. Kokre. Sir is a practicing OB-GYN IVF consultant, President Baramati OB-GYN Society. Dr. Srihari Lahane, President Beat Obstetric Gynec Society we are in Vitai Hospital and Research Center B. Dr. Sheila Shelke, she's a secretary, Sevargram Varda Obstetric Gynec Society. Dr. Yashwant Pawar, sir is a president, Chalisgaon OB-GYN Society, Director Mauli Hospital, Chalisgaon. Welcome, sir. Over to you, Dr. Parasuram.
I'll just share my presentation. So a very good evening to one and all. I think you've had a very elaborate and a detailed discussion on several smaller aspects of infertility and very interesting talks on sildenafil. Unfortunately, I think Dr. Parish could not, I don't know what happened. I don't know whether it's some kind of a connectivity issue or whatever it is. We could not have him before me. So today when I was actually asked to talk about a male infertility, I think thanks to the esteemed panelist, I think we are very senior people. I'm so proud and happy to actually kind of moderate them and get a lot of very important messages across. So what my whole idea in this particular panel discussion is to make sure that I'm trying to bring out the basics, more importantly. Because of the challenges of online, I would request whoever will be able to kind of give an answer to actually kind of give the answer, because I might not be able to name each one of them. And okay, so whoever is able to contribute to one particular question that I'm asking can actually answer that, and somebody wants to add on to something to that particular topic can also talk on the same. So again, I welcome all my esteemed panelists. It's truly an honor to be moderating the session amongst you. As the first question, I know all of you are very senior specialists. Do you think there has been an increase in incidence of infertility in your routine practice? What do you feel?
Yes. Hi, Parsu.
Yes, sir.
Good evening, and thank you for giving us this opportunity to be here with you and exchange our thoughts on this. Yes, there is definitely an increase in the male infertility overall. Also decreases depends upon where you are practicing for a few reasons. Like if you are in a city like Pune or Bangalore, or where IT crowd is quite more. In that case, the timings are quite an issue. Their time, they are working at a different time zones as compared to what normally we should be working at. That's number one. Number two, there are quite a few belts wherein chemical factories are quite a lot. So if the person is residing in an area which is close to these, there has been an increase in the male subfertility which we have found across, because I'm working in such a place where we have an OPD at in the chemical belt, and we find lots of male subfertility patients there, especially because probably of the pollution which has been there of the water through the chemicals which are released from these factories.
Perfectly, sir. I think probably one of the first topic what he spoke about the actual challenges of not having time for sex or probably avoiding sex, and the whole challenge of decrease in sexual frequency is actually very common nowadays than what we were seeing.
So there's a terminology which has been coined for it called as DINS. So it's called as double income, no sex.
So no, it's actually very true, and probably today we see a lot of our patients actually having this issue rather than a proper fertility problem or anything. So that is what I was trying to emphasize here, is that okay, we have been always talking about that whole 30% male, 30% female, 30% what do you say, unexplained, 10% is both. But I think today we do tend to see, especially in patients who are on long-standing infertility, we tend to see that there's a little more, there is more contribution, or there is more number of people who there is actually a more contribution as far as males are concerned. So why do we actually think that? Because see, we gynecologists are very good experts as far as female fertility is concerned, and we know that most of gynecology, we are very well aware of how this needs to be corrected, how this needs to be treated. But when it comes to a male factor, or when it comes to a female factor, most of us unfortunately are slightly ignorant. See, now if you look at how many of us gynecologists do actually examine a male partner, again, they only do a semen analysis and probably see some abnormality in the semen, and the patient is immediately referred to a andrologist. And what is more interesting is that we know that whatever may be the issue, sometimes we don't have an answer for it. Sometimes when we evaluate all of them and we realize that there is no answer to this, so probably we just put them on different kinds of antioxidants and leave them. So basically, so when you see a person with a male fertility issue, or when you want to actually evaluate a person, a male partner, and to be honest, this is probably the first investigation. The males are the first people that needs to be investigated. A lot of times what happens, the females come alone for evaluation for fertility. It's very important that you always see them as a couple. And one of the first investigations that needs to be done is also a semen analysis. So how do you start off, sir? See, do we have any other panelist on the who's joined us?
Dr. Aparna Rahul from
Yeah, please.
Aurangabad. I've joined, but I'm in this panel, sir.
Yes, you are in this panel. Yes.
I'm so sorry. Right now, 5 webinars are running, and I am a panelist in another one also from polyhydramnios. I have jumped to male infertility.
That's the
Dr. Aparna, Dr. Aparna, you are so popular.
No, I'm not popular.
Dr. Kanchan has also joined. Dr. Kanchan has also joined.
Kanchana, Dr. Aparna, everybody's here.
Sir, what is the question? Can you repeat?
No. I would like to ask you, like, see, what are the basic investigations the male you do? Obviously, I know that you'll do semen analysis for them, but other than semen analysis, what are the other tests that you'll do in males?
We do hormonal profile of the patient, serum testosterone, like if there is
Yeah. So the first point is
parameters are not normal.
Yeah. Madam,
If the parameters are not normal. Hello?
Yeah, please tell me, madam.
We do a basic, sir, profile, like blood group is very important. And then we do this hemoglobin electrophoresis also to rule out thalassemia minors and all. And then hormonal profile, if there is any problem in the serum parameter, blood sugars, thyroid profile, FSH-LS serum testosterone, if there is a problem with oligo or period like that, and if there is severe oligoasthenoteratozoospermia, we can also do DNA fragmentation index.
All right, I'll come to that, madam. So you strongly believe that in a normal scenario, all that is required is a basic blood investigation so that you don't rule out anything, you don't miss out on anything on this patient, and a basic semen analysis. Yes. That is what is required. And only when you see there is some kind of an abnormality in the semen parameters or some kind of deficiency in the semen parameters that you will want to evaluate them further by doing other hormone tests like thyroid evaluations, FSH, LH, testosterone, all those things. We'll come to this in a little more detail in the remaining slides. But how many of you do think of doing an ultrasound for any kind of when you see a semen abnormality?
I do first thing, color Doppler and this.
You do a color Doppler. So you prefer a scrotal ultrasound or do you do a transrectal ultrasound? What do you generally prefer?
I don't do myself. I send to the sonologist.
I agree, madam. I do understand. But see, what do you think, or what are you going to benefit, or what are you going to understand from your scrotal ultrasound?
Any varicocele present, hydrocele, then testicular size, the fullness of epididymis, I think they can see, and truss is depends on if they want to see the seminal vesicles, I think.
Yes.
If there is an outlet tract, like obstruction in the outflow tract.
Any other panelists in the group can actually say that what is today as a relevance. Do we actually recommend ultrasound or a basic examination is what is recommended? I do understand one of the challenges.
We don't examine, sir, patients ourselves, so we like to do ultrasound.
All right, but is ultrasound, the question here is again, is ultrasound sometimes misguiding us? Sometimes that most of the time we do end up seeing most of the people.
My take is here, even if you say diagnose varicocele, okay, if it's grade 1, grade 2, grade 3, grade 4, grade 1, you don't do much about it. If it's in grade 3 and grade 4, are you going to do a varicocelectomy for this patient or not, is a question what I feel one should ask ourselves. And the answer clearly is no, we are not going to do a varicocelectomy for this patient, and we would be advising him to go for an ART procedure instead. So,
sir, let me ask you, which group do you think actually benefits from varicocele? Have you ever thought that is there some group of people who actually benefits from a varicocele surgery?
Not really, actually.
Okay, all right. So, kind of the understanding nowadays is that yes, when you do a scrotal ultrasound, there's a lot of mismanagement in the sense that they end up getting a lot of patients with grade 2, grade 3, because they themselves have 3 or 4 types of grading of varicoceles, which again gets a little confusing for the doctor when you're actually reading the reports. So generally, when they say when there is an obviously physically palpable varicocele is the only place which needs to have some surgery. But then again, when you're doing a surgery, it is very important in this group of patients to understand which, see, we have to rule out other factors. When you see a OAT, we should rule out other factors, like we should rule out other endocrinological factors, should rule out all the FSH values. Is there some other issue that is probably contributing to the OAT? And if that is there, then probably varicocele might not help you. But if you see varicocele as the only finding and rest all the parameters seems to be good, there is only some OAT with not very severe OAT, but some mild to moderate OAT with varicocele surgery, and all the reports are normal, probably that is chill. But whenever you do these group of patients a varicocele surgery, we should also tell them that we have to wait and evaluate and see that the patients are also there, like who might not have any response. So we should always go there with a caution and talk to them and tell them that this is a probable treatment. Because we don't find anything else, we can do this. So anybody else can also contribute on karyotyping on chromosome. In which group of patients do you actually think of doing a karyotyping and Y chromosome microdeletion?
Patients with severe OAT and azoospermia to rule out Klinefelters and Y chromosome microdeletion in patients who are going for ICSI, because it depends on which A, B, C there is microdeletion, and there I think A is there. I'm not sure, but A is there. If we do ICSI, then there is a problem. This can be passed on to the progeny.
So it's more, it's more from the counseling perspective rather than treatment perspective. So we have to counsel that the offspring can also land up in similar kind of a situation when he grows up, if it's a male child.
I think the only place
also, sir, we can advise if there is a structural read balance translocation in those patients, PGT SR can also be advised.
Yeah, right. So it's primarily for counseling and some kind of an additional treatment that might be required during the procedure, that we might utilize these karyotyping by chromosome microdeletion. See, one thing probably where I see Y chromosome microdeletion in the picture today is that in patients of with non-obstructive azoospermia, where you want to decide whether you want to do a micro-TISA or not do a micro-TISA. Somebody with a deletion of A and B, you need not even proceed with it. We know that you don't get sperm. Whereas if the deletion is only of C, there is a possibility, or the reports are normal, there is a possibility of getting sperm. It does not tell you that it will get sperm for sure, but at least you can give a negative counseling is easier. For example, if deletion is there, see, for people, for the general audience to actually understand what A, B, and C means, imagine like how Dr. Sanders Estes always talk about, imagine like a manual of producing sperm. A is the first chapter, B is the second chapter, C is the third chapter. If A and B is not there, if the deletion is there, that means that they've not been able to make the sperm only. They've not even started making the sperm. So there's a very high possibility that you don't get a sperm, even a procedure like micro-TISA, whereas in C, it is only the finishing of the sperm that is there. So there is still a possibility of getting sperm. So C is probably that group of patients, even with microdeletion, where we can proceed with procedures like as micro-TISA, where other procedure, if it is A and B, you need not go ahead with a procedure like micro-TISA. And somebody can talk about advanced sperm function test. Where do you do it? Madam did, I think, mention that if there is a severe odds.
Viability, to see the viability and how many embryos we will be able to get if the horse positive, to see whether
Madam,
this sperm will be like.
That comes in the basic analysis. But as far as the advanced sperm function test, what do you generally suggest, in the sense, you did talk about DNA fragmentation.
DNA fragmentation index.
Yeah, madam, one question I had with DNA fragmentation index is, what are you planning to do it in patients with severe odds, or do you want to do it in patients with mild to moderate odds, or somebody even with unexplained infertility is the group that we want to do? Because what do you think? DNA fragmentation is anyway going to be high in patients with severe odds. So is there actually a point in actually doing that test, or we should do it in those group of patients where we are not able to find a reason? And
unexplained infertility also, it has importance to find. Like if there is nothing to explain, then we should do DNA fragmentation.
Yeah, but I think
reactive oxygen species,
other medical disorders like diabetes or obesity can also have a high DNA fragmentation index.
Correct,
in spite of the semen analysis being normal as far as the count and motility is concerned. So in those cases, we have unexplained kind of an infertility. So their DNA fragmentation could be high. So this is a subgroup of men in whom we can do, or we should do, a DNA fragmentation index, even though the semen parameters show mild or moderate OAT, as you said.
So also in patients who smoke and tobacco chewers, they have the high.
Yes. So, but then do you do this as your first line investigation in a patient who comes with infertility, or you leave it to one IUI failure or probably one IUI failure, then only do it? What do you generally do it in your routine practice?
It is a costlier test, so I do it later for my point of, from my.
Even I don't prescribe it at the first line of investigation whenever the patient comes. So as you said, if there is a failure for one or two IUIs, then maybe yes, we ask them to go for it.
Now the second tricky question is, if you find high DNA fragmentation, what are you going to do about it?
Depending upon what is the percentage of DNA fragmentation. So if it's between 15 to 30, maybe I would ask him to take some antioxidants for a few months, change in the lifestyle. I don't know how much it is going to help, but it helps me in counseling the patient afterwards, to be honest. If I'm giving him the antioxidants for 3 months.
Otherwise also we are giving antioxidants to everybody.
So it helps me to counsel for the further question, further course. Because if I ask him now, your DNA fragmentation is high, better to go for an ART procedure, they may not accept it immediately.
Correct, sir. It's
for that I need some time, and that is where these things may come handy.
Correct. It's primarily used as a kind of a counseling tool, or probably help us in. Madam, you're talking about oxidative stress. Are you doing any test for oxidative stress? Because that's also now commercially available. I think the test for oxidative.
They have kits. The kits for it. I had seen in the conference. I think ISR Hyderabad, but I have not personally used them.
But these are all done very rarely. These are tests done only.
More of theoretical significance than practical significance, probably.
It has been brought up quite actively in the 6th edition. They're talking a lot about DNA fragmentation. They're talking about fish analysis of the sperm, oxidative stress. They're talking more in detail of these procedures, but what to do with these procedures, or how do we actually manage with these procedures, they've still not talked about. So I don't know whether we should start doing it for all our patients, or should we wait for more evidence to come in. So tentatively, what I always understand is that we can always divide, or probably this is how in our center we always find, is we always divide the group of patients with OAT into 3 particular groups. That is, one, we have an explainable, treatable reason. For example, you know that there's a varicocele, we know there's a hydrocele, there's a diabetes, pyospermia, there's some kind of endocrinological issues, some kind of social problems with their smokers, excessive alcohol. So you know that there is a problem, you know that problem is treatable. Then this next group of patients, we know that there is it's explained, we know the cause, but we know that at the same time this cause is untreatable. For example, testicular failure or chromosomal abnormalities, somebody with on chemotherapy. We know that there is an issue there, but we still don't know, but we know that there's no treatment also. And then there is this group of unexplained group of patients whom we can never find a cause. Sir, in your experience, how much percentage of your group of patients fall into this third category?
Quite a bit. I would say most of them are in that category.
Exactly, sir.
I always say that women, the amount, the number of issues or problems that a woman can have, factors, are more, but most of them are treatable. While in men, the cause is less or the investigations are less, but if we have any issues or problems, it's very difficult to treat that.
Exactly, sir. So technically what we understood is this explainable treatable is probably only 20 to 30%, very less group of patients where we actually find a reason we are able to treat. This explained but untreatable is very less than 5%, very less group of people.
Right.
Whereas the 70% or the major chunk of people who comes to us with some kind of a male infertility is actually the unexplained, where we don't know anything about how to treat the patient also. So when we don't know what to treat or how to treat, how do we manage this group of patients is the question. So let's go back a little more back to the basics. Because I think we have a lot of newer gynecologists, younger gynecologists who probably want to know a little more about the basics than to actually go very advanced. I think we did cover a lot of advanced in the previous lecture and also in the initial part, but I'd like to go for basic things. Like one of the most important thing is the semen analysis. Sir, what do you think has changed in the last 10 years? From 2010 to 2020, what do you think has actually changed as far as the semen analysis is concerned? And do you think it is really going to change your management as far as, do you think this is going to really help you with this management?
So there is a bit of a change between 2010 and 2020. As you can see, the count has from more than 15. They said that the normal count should be more than 16. Motility more than 40 has increased to more than 42. But there is not much of a change which has been there. And therefore, as far as my practical treatment of the patient or the approach to the patient is concerned, I don't think that there is much.
It's not really changed.
No.
Different changes, because that itself is a completely different lecture. But now, like I said, basic questions like, what do you think, sir, is an ideal situation or ideal period of abstinence for a semen analysis? Because all of us do semen analysis for our patients. What do you tell your patients, or how do you actually counsel our patients? They can just come and just take the semen, or do they really need to have abstinence? They need to have weeks of abstinence. What do you tell your patients regularly?
So weeks of abstinence is not recommended for sure. 2 to 3 days of abstinence was what we used to recommend previously. But nowadays, there are quite a few papers which have been published. Those are related to obviously an IVF, that a single 1 day of abstinence would probably give me a better sample than more abstinence. But as a routine, we follow 2 to 3 days of abstinence.
Now, what does happen if there is more days of abstinence, or what will happen if it is lesser days of abstinence? Somebody can answer.
If less than 2 days, the count will be less. And if more than 7 days, then abnormal sperms will be more.
Motility is also affected if there is a huge gap, or abstinence is more for more number of days. And free radical injuries are also seen to be more in those who have more abstinence.
Yes, I think the emphasis here is that, see, whenever we talk about it, I think we should not blindly go with the idea that we should actually have see what is there. Sometimes the patient is coming from far away. We might have to look at the semen analysis at that point of time. So you should understand that when there is a longer absence, there's a higher possibility of increased percentage of dead sperms in the semen sample. When there is a shorter abstinence, see, basically it's the overall semen volume that is going to different. It can be probably the volume of semen that is ejaculated is going to be little lesser, but per volume, per ml, the count or the motility, everything will be same. But it's only going to be the overall volume that is going to be lesser. Because overall volume might look lesser, we might think that the total count might be less. But if you look
Correct.
at it per ml, that the quantity will not be different. So it's the shorter the absence, the only difference that is going to make is that. And today, when we're talking about using these sperm procedures like for IUI and things like that, we do understand that the lesser the abstinence is always the better. You really do, as long as they're able to take the sperm and give us, it's better to have the shortest of abstinence possible in these kind of procedures. Like I said, sir, if you can even tell us, see, what do you think are the drawbacks of a semen analysis? Why are we always worried about we know that that is the only test or the test that we all depend so much about in our day-to-day practice. But but what do you think as the biggest disadvantages of a semen analysis?
As we were just discussing about the abstinence, one of the reasons why we want to have an abstinence is that probably we would like to have the report which is closest to what it actually is, and therefore that itself suggests that there are parameters which keep changing from sample to sample. It not only from sample to sample in a healthy male, but if he has got some past history of illness, like he has come out of some fever or anything, that also is going to affect the parameters. Therefore, it's changing from sample to sample. Then that is why we say that one sample, if it's an abnormal, we will not rely on that, and we have to do a repeat semen analysis about 4 weeks apart. Now, why is that so? That is because one sample may give us a wrong information. Therefore, the same kind of an abnormality should be seen in two different samples given at two different time zones. So that is one thing, and it does not assure that the man is fertile with the best parameters. Both way, both extremes are true. That even if you have a normal semen parameters, that does not guarantee that he will father a child, and even if he has got, say, less number, still you can have surprises and they just become pregnant. And therefore, again, counseling them that you will not father a child anytime would not be the right way to go, because sometimes you do get pregnancies even out.
You always end up telling them that you can never have a child, and suddenly the next month they'll come back pregnant. So I think, like sir was very clearly saying, I think all we can say is that you're having a higher possibility of getting a child, whereas you have a lower possibility of getting child. As long as it's not azoospermia, I think we should always tell them or talk to them saying that yes, the possibility is less, but so we might need to go for some kind of treatment. And there is another very interesting factor that we always talk about, is a man can be fertile to one but infertile to another, because see, sometimes it is the combined factor. See, always, whenever we evaluate, I think it's important that we evaluate the couple, because it is just not the man that is important or the female that is important. It is how they function together that is important. Sometimes that even with very poor semen parameters, sometimes the female partners are so fertile, even just that one sperm that going inside will actually give them a pregnancy. Whereas in patients who are having poor ovarian reserve, or somebody who's got PCOD, who's going to ovulate once in 3 months, once in 4 months, but having regular sexual life, the semen parameters are so good. Those are group of patients probably even with a normal or less good semen parameters with difficult female problems also get pregnant. So sometimes, see, like how mathematics says 2 + 2 = 4, 3 + 1 is also 4. So similarly, it can be sometimes one parameter. See, I think going back to the time where we actually look at not times, but even today we look at horoscopes to get married to. So probably I think all of them do have a role to kind of tell us that this probably are supposed to be together. There is some problem that one person's deficiency is covered by your partner. So I think a lot of times it happens in that factor. Like I think sir was emphasizing so much on the inconsistency in your semen sample reports. I think one of the most important factors, yes, is the masturbation. And unlike your blood where you take it out, or unlike your urine that you take out at every time you go and take it out, masturbation, fortunately, unfortunately, is related to your whole mind, thought process, everything. So if it is not very comfortable, obviously, how you're going to go give a semen sample in your lab. Not everybody will have a semen collection room. A lot of times you might have to end up going and collecting in the bathroom. You're not comfortable, and obviously, as a man it's concerned, it might be a little difficult for them to even get a proper erection there and actually able to do the collection. I think how many of you would actually kind of recollect that movie? I think the one which we had the mix-ups, where actually Akshay Kumar goes to the place and they had a very luxury room that is there. So it's actually a dream for every patient to even actually have a room like that to actually collect the sperm. And in that room, they were finding it difficult. So imagine our normal poor patients who actually goes and tries to collect the semen sample in a very dingy, small room with very less ventilation, very less space, or sometimes into a bathroom where you get it. So I think it is very important that we provide them a facility where they're able to properly, or in all good ways, be able to properly masturbate and give you a good sample. And then sir also did talk about, I think this part also sir did talk about. Like I said, I think you are following the 4 weeks. Right. The same reason. Actually, now when you say the old customary was that, okay, yeah, the semen that is produced probably it's in a 3-month cycle. So you need to actually take it only after 3 months, then the next lot of sperms are going to come. So you'll be able to know it. But that is no more concern, because today collecting the sperm is today's issue. Sometimes it can be just the stress today. It can be that you do not have a good day today. Even repeating a semen sample in a week to 10 days or 20 days is even good enough today to actually understand if there is a major abnormality. Sir, what do you actually do when you see samples with fluctuating? Some samples are giving you a very good report. Some samples are giving you very poor reports, all from good labs. Now, that I want to emphasize, because now most of your labs you end up giving a semen report. Everybody
how the semen sample is collected, the instructions that are given to the person before collecting the sample are equally important, because majority are concentrated, the sperms are concentrated majorly in the initial part of the sample. So if it spills over and then the later part of the sample is collected, that itself can give you changes or variations in the semen sample or analysis. So that is very important. That is why I always prefer to do it in my my own settings rather than relying on some other lab. But I mean, that's not possible for every person and every setup as well, because we have ART lab. That's why we can do it. But if for a general gynecologist who doesn't have a lab, it will not be possible for them to get the semen analysis done at their center.
Yeah, but at least you need to do it in a reliable lab.
Yeah.
Your reliable report. I think that is something.
And if there is something which is like CASA is available somewhere, then more the merrier.
But do you really rely on a CASA report, or are you happy?
See, the only advantage that you get there is, say, suppose you are doing it from a pathology lab. Suppose, then it may not be the pathologist who is looking at the slide. It may be the technician who is looking at the slide. We don't know what is the experience for that technician. So there, the human factor is removed. That's the only advantage which I can see on doing it on CASA. At least the reproducibility of the reports would be better.
And see, that's a very important point, because see, when you actually do it with good technicians, probably CASA is not going to give you an advantage. But when you're doing it with technicians where we are not sure of the quality, different technicians doing it, different labs they're doing it, probably yes. But again, there's a big debate as to cost versus benefit ratio and things like that. But already somebody's invested in it, I don't think there is nothing that needs to be discussed about. But if it is something that we have to discuss, where we have to do it, then it is probably like sir was saying, it's more reliable.
Yeah, see, because when you say a good lab, the good lab is by its brand. You don't know on that particular day who is behind the wheel and who is doing the reporting actually.
Sir, when I say good lab, I think one more important thing that most people should also understand is that a good lab which is probably doing semen analysis on a regular basis, not regularly a lab that is probably much very good in your other blood investigations. You might have multinational brands of labs which are running in your periphery, who are doing a lot of blood investigations, hormone investigation, things like that. Probably semen analysis is not the forte in which there might be an expert in. So probably an IVF center which is nearby, or because we as a center do get a lot of doctors who actually send patients to us only to do a seminal analysis because they're convinced that probably they'll be able to get the report. So that is one thing. Madam, you're still there? I hope you're not in the other panel or this. Yes, doctor. Can you
Kanchan is there. Kanchan can take this.
Can you just tell me?
Dr. Rajesh sir has joined. Madam is still there. Yeah, Madam is there. Dr. Rajesh Kokre sir has joined.
Yep,
He can also answer your questions.
Dr. Rajesh, if you can see, you end up seeing nowadays one of the biggest question that or biggest challenge that is coming.
Hello.
Yes, sir. Rajesh sir. Can
Yes, sir. Yes.
Yeah. Welcome, sir, to the panel. And
Hello.
One question that I had for you is that today, now that we are talking so much about that it has to be done from a good lab, it has to be done in a good way, it has to be done perfectly. But then the challenge here is that we end up seeing patients with 5% morphology, 4% morphology, 7% morphology, and the patients are worried. The patients are kind of scared. Is it my sperms are abnormal, whether my child will be abnormal? How do you counsel these patients, or what do you think is how do you talk to them, and how do you reassure them when you see such kind of reports?
Actually, after seeing the report, we first of all our first of all doctor himself has to be sure, understand, and start reading the report properly. So probably, as we say, if we get a chance, if we get an opportunity to go and then see for the morphology of the sperm, usually what we do is after doing the sample, we ourselves can see the slide and see for the morphology of the sperm, and whether it is the moving sluggish sperms are there, or it's progressive forward movements, and depending on that, once the count is there, sometimes 5% surface abnormality is there. So patient has to be assured that sometimes if whatever the report is there, that the quality of the sperm has to be improved. And if there are some abnormal sperms, we're giving antioxidant lifestyle modification. If the patient is smoker, ask them to stop addictions. That has to be, that we have to counsel, and probably good protein diet. That is what that all the counseling part would be, so as to assure them that but there are the chances that if which sperm is going to, during the normal procedure, which sperm is going to fertilize, that is not, that nobody's sure. So on that, patient should be assured that as the sperms are going to be good quality sperm, which that will be dependent on that. And for that additional the medicines, what we gave, lifestyle modification, I think that is the way we can counsel the patient.
Sir, one thing that we always end up doing, actually, whenever we see these, now we were so much emphasis on the quality of testing and all those things. Okay, with the higher quality of testing and with the use of the new guidelines, we all know that we need to look at the morphology, like how the Kruger is actually said. And Kruger is saying that even up to 4% is considered, if only 4% is normal, it's considered to be normal only. So we should, I think probably how we assure the patient is like, see, normally my patients who get worried and come and ask me like 5% is it okay, 6% is okay, is basically like, see, the way that they have actually tried to kind of categorize the semen is like you're Miss India pageant. Like you have to have a hip of the size, you have to have a shape of the size, you have to have a height of the size, which normally does not necessarily mean it's a normal female or not. So similarly, a sperm morphology, even just like anybody can have a little longer nose, somebody can have a bigger ears, somebody can be taller than the normal. But as far as Kruger is concerned, that is abnormal. So we always end up marking a lot of abnormality in the sperms, and we can only consider it as to be grossly abnormal when there is more than 4% or less than 4% normal morphology, is where we probably need to be worried and need to have some kind of treatment. But the challenge again is that even if even if like there is some kind of a minor abnormality in your 7 morphological parameters, do you think it is really clinically significant? Chaitanya sir, is there?
No, I don't think that it is clinically significant.
So most of the time you know that, but then the only problem is that when you see a patient with very gross abnormality, are we able to actually understand why it is happening or why is the reason, and are we able to treat it? All of us give antioxidants and everything, but do we really know why this morphological abnormalities have come in?
We don't know why it has happened, and because we don't know why it has happened, we cannot treat it as well.
So
we can only treat if, the cause we know of, and if we have a treatment for that, obviously.
But we can take out better quality of sperms with IUI, like preparation, semen wash preparation techniques.
Madam, technically we look at it as that we are in semen wash. What is happening is that of the content of the semen, we are isolating the better part. We are not improving the parameters.
Dr. Parsu, even when you are doing a semen processing, are you actually filtering out abnormal sperms, or are you filtering only those who have got less motility?
So it's basically a motility based. Most of these tests are
exactly. So it is motility based. It is not abnormality based. Our process.
One more thing I would like to add: even the centrifugation, it's being done, depending on that, also the quality of the sperms is going to matter.
Yes, I'll come to that, sir. I'll come to that. We have a little more discussion regarding IUI after this, so I think we'll cover all that during that time.
Yes.
So now we did talk about FSH we did talk about a hormonal analysis. How was FSH helping you, or what is your benchmark of FSH? When we see a male patient, we see an OAT, we are doing hormones, we do an FSH. Okay. Do you have a cutoff? What do you understand when there is FSH is, say, for example, 10, 12, 13? What do you understand, and how do you manage these group of patients? Anybody can add?
So raise
the advantage of doing FSH in these patients are that, number one, that if the FSH is going to be on the higher side, if it is on the higher side, we don't know the reason why it's going up. So if we don't know the reason, we don't know what's going to happen tomorrow. So that is going to tell me how much time I have in my hand to correct and to try to correct these abnormalities, I would say. So that is where FSH will give me some hand again for the counseling of the patient.
I think Dr. Kanchan wanted to add something.
Sir, actually, it is not only. It should not be considered as a only. Sometimes while counseling, it should not be considered as the only marker. Like if it is a raised FSH, that we have seen in the patients with raised FSH also we got the sperms with TISA. So it should not be the only point for counseling the patients with severe OATs. Though it can be one of the point where we can, if there is a raised FSH, that is, it is more than 12, more than 10, more than 8 actually is the theoretically more than 8 is the level. But if it is more than 12, then the chances of sperm retrieval will be less. In azoospermia, basically. In azoospermia.
Yeah. See, obviously, FSH is a very important test as far as we very strongly, or we do these tests, and actually most of our treatment primarily depends on the FSH, LH, testosterone test, and like that. And of the lot, we very strongly believe FSH is probably one of the most important tests that is available, especially in these severe OATs patients, because it tells us probably. See, we all today know that in females, an FSH above 7 or 8, we do understand that the reproductive outcome is lower. Similar to that, today we even have American Andrology Association all do talking about saying that an FSH in males above 7.3 or something is considered to be some kind of an impending testicular failure. So if you know that there is an impending testicular failure that is going to happen, you know that you need to do the treatment faster. Obviously, whenever these patients come to us and when we see a severe OAT, we end up putting them on medical treatment, and we keep on putting them on this medical treatment for years sometimes. So, but we should understand that the FSH is higher. The possibility for these people to recover or improve by giving medications are lesser. The higher the FSH, the possibility is much lesser. And what the doctor was talking about is, especially in azoospermia, there is nothing that can tell us that there is no cutoff, which tells us that beyond this, there is no sperm available. Higher the FSH, the possibility of getting sperm is lesser. It is not that it is not there. The lower the FSH, the possibility of getting FSH, getting sperms in a sperm retrieval technique is better. But doing an FSH, especially in oats patient, will give us an idea of probably there's some kind of a test club dysfunction that is happening, and we need to utilize the time for treatment and not delay treatment for a very long time. I think that's emphasis or the take home from that particular reports.
So do you want to say that, say, suppose I have a patient of azoospermia, and to differentiate between obstructive and non-obstructive, I did an FSH, LH, and testosterone, and I find that FSH and LH both are high, testosterone is normal. Or lower, I would say, normal, lower range of normal.
Yes.
Now, it's more likely that it is an testicular failure. But should I subject even these men to trial TESA, or I should counsel otherwise and straight away go for donor IUI?
Sir, there are two ways. Now, again, two ways we probably end up counseling these patients. Now, the FSH is not very high, probably say 10, 12, 13, which are reasonably normal size testes. The testosterone is still there. Probably those group of patients, we can always think of offering them a trial TSA. Now, in patients with little more higher FSH or even more higher FSH, smaller testes, all those things, we can probably, we know that probably getting sperms in them with just TSA might be lesser. We might have to think of micro TSA or procedures like micro TSA. So we can be well prepared of. But technically, when to do this procedure, now a lot of people are there, whether we should do a trial or do the procedure at the time of home pickup is important, because when you do a trial, the challenge with the trial is that we might not do multiple pricks at the same time when you're doing a TSA. We might take few pricks and understand that that sperm is there or not. If you're getting the sperm, well and good, it is fine. But if you're not getting sperm, we can never say that if you take more biopsies, we'll not be able to get sperm.
So only drawback of not doing trial TSA is that if the couple is not willing to use donor sperms, and we are not sure whether we are going to get the sperms, then the stimulation and everything would be an additional burden or cost physically, mentally, psychologically to the patient. That is the only thing if I don't do a trial test. The advantage which I get is that I can counsel the patient that yes, it's quite possible that we are getting the sperms, and so we will be able to get it at the time of the ovum pickup as well, if we are doing it. But as you rightly said, there are drawbacks of doing it as well. So if the couple is ready, okay, fine. Even if I don't get, it's a waste of my cycle. Or if she is willing to use donor sperms, if you don't get a sperm at the time of TESA, then probably avoiding a trial TESA and going straight away for a TESA at the time of ovum pickup makes sense.
So, sir, I think even if you actually listen to Dr. Now, most of the time, even though we talk about all these things, most of the time, especially in these patients with high FSH, now these micro TESA are preferably done at the time of the procedure, not done before. Unlike before, where you used to do a micro TESA, a trial micro TESA earlier. Nowadays, most of the micro TESA, we always this involves a lot of intense counseling.
So micro TESA is a different ball game altogether, isn't it? Because you have to we keep on dissecting a lot. You have to have a lot of time, and everything is spent into it. So when it comes to micro TESA, as you rightly say, it's quite right that if we do it at the time of the ovum pickup. So there is a little difference in the. That's what my opinion is. I mean, we can always agree to differ. Yeah.
Because the challenge here is that always there are not many centers don't have the provision to have a micro TESA. Now there are very less people in India probably who can actually end up doing a micro TESA. Not even andrologists or urologists are very familiar with this whole process. So I think yes, trial TESA can be done, or trial TESA is probably the one area.
Another point what you have brought out, important point you have brought out, is that examination of the clinical examination of the male partner is equally important. As you said, depending upon the testicular size, we can judge whether we would be able to get sperms or not. There, that is one point which I feel that is equally important. Many times we tend to overlook that, or we don't do it.
That's what, sir. I think even though when we look at the different scenarios, see whether testicular size, FSH, all of them, unfortunately, till today, like what doctor was telling, no, even with high FSH, we have got sperm. Yes, we can get sperm. We have seen, I've had reports from in our local centers where some clinic here who said that they got a sperm from microtisa in patients who had an FSH of 80, which is like unbelievable. How can somebody think of getting an FSH when the FSH is so high? So, but then they've got it. They say to have claimed to got it, and we can believe that also. So, but that is what the whole idea is. You can never use it as a cutoff. We can only use it as an idea or understanding that there's a higher possibility of getting sperm and a lower possibility of getting sperm. So that is the only thing that you need to understand in the scenario.
Yeah.
And madam, how do you normally offer your patients that, or how do you advise your patients, or what do you think is a good sexual frequency, and do you believe that a good sexual frequency will actually improve your semen parameters?
Yes, sir, because it decreases, DNA fragmentation is less if we have frequencies more, and then the chances of conception are more.
So again, the question here is that in these patients, most of your patients, do you prefer them to do a timed intercourse, or you ask them to have regular sexual life?
I usually I've seen that the patients themselves, they think that if they have got an IUI cycle, then they don't perform natural intercourse, and then they tell us directly that we are having abstinence since 10 days, 15 days. So initially, when you start a cycle at the time of starting induction, I explain to the patients that it like you can have your natural frequency, and then before doing IUI, when I usually give them only ask them to have a gap of 1 or 2 days only before IUI. Rest of the time they can have their natural frequency, whatever they are having.
Perfect, madam. I think
so definitely the timed intercourse would improve the chances of conception for that couple. The only thing that happens here is when we ask them, it has to be done today, it has to be done tomorrow. So it is not something mechanical. As you rightly said, there is a psychosexual path which is involved into it. And therefore, it becomes difficult sometimes for the couple to perform when we ask them to perform. And that is the only thing which may go wrong when we ask them to have a timed intercourse. Now, in that case, maybe we have to, there are quite a few times that we have to say, don't tell husband. You go and have naturally. Don't tell that I am ovulating today or I am ovulating tomorrow. It may have an impact on his performance. So that also sometimes we have to do.
Correct. I think no second thoughts. I think probably.
That's what we call as that night syndrome, sir. That is what we call as that night syndrome. When you ask them to do sex on that day, they cannot perform because of the psychological component, that the situational anejaculation or erectile dysfunction they will have. So
a new syndrome is added to my list today.
Because I think today, like I said, coming back from where we started the lecture as to we have these patients today who have got bad PCOD, very irregular cycles, will correctly only have intercourse on the 14th day of the menstrual cycle, where ovulations never happened at all. And other time they will not have sex because they'll think that even if something like that happened, I might disturb your pregnancy. So that is one big challenge that we are seeing in a lot of our current group of patients. And like Sir said, see, timed intercourse, if you look at technically timed intercourse is a good thing. But what happens is when timed intercourse becomes too much of a time thing, then it becomes an unnecessary stress and challenge for most of the patients.
Very many data says that if we have 15 to 20 times sex, they have 84% chances to conceive. Whereas if they have a timed intercourse of 4 times around the ovulation, they have 12% chances to conceive. And if they have exactly 1 day on the day, they have only 2% chances, sir. Because the prolonged abstinence will reduce the sperm motility, the count, as well as the quality, and all the sperms will be dead sperms. And they've even conducted one thing in CMC Vellore. If they have more than 7 days abstinence and getting a baby with that older sperms, they have an increased risk of autism also. So this has been a published one. So all these things has to be interested. So make it as a natural way. Pregnancy is the normal physiology. When you have more time sex, there are more probabilities of getting pregnant. So that should be the attitude.
A byproduct. Yeah.
Yeah, but so the problem today is when they have regular sexual life, they don't want to have a child, and when they want to have a child, sex
They cannot do it.
Absolutely. Absolutely.
Okay, anyway, just a quick recap. What do you think is the principle behind an IUI? I think Sir was talking about IUI earlier. Somebody, Madam was talking about IUI. And what I was trying to emphasize is that, see, we are not going to improve your semen pair. Whatever sperms are there, we are isolating the best part of that particular semen, putting it into a place that is closest to the place of ovulation, around the time of ovulation in a hyperstimulated cycle. So probably that is where we have the maximum benefit of IUI. Yes, what are the basic indications? What are the real indications of IUI in male infertility? If somebody can answer this quickly.
Hello?
Do you think IUI is good for severe OET, bad OET?
Yeah, IUI is good for patients who are having some problem with regular sexual intercourse. They have sexual like their count is normal, but they are not, they are unable to perform properly. Then if the patient has azoospermia, then we need to have a donor insemination. Then, as you said, in the cases of PCOD or other patients in where we are not sure when there will be ovulation, or in cases of severe ovulatory dysfunction, they are better, they are benefited by IUIs. HBsAg, sir, you have written in the slide infectious diseases like HIV, but the sperms, if they are washed, the HIV virus is not removed. But in HBsAg, it is beneficial.
No. Even for HIV, it reduces the viral load considerably. And if he's on antivirals, that itself reduces the viral load considerably. And in addition to that, if you perform an IUI in these cases, it definitely reduces the chances of transmission to the partner.
But there are, of course, chances of transmission. So why to put her in a risk?
I'll tell you what
it's one in but Dr. Basu, you can tell.
See, madam, what you said is actually correct. Theoretically, they say that now the whole idea is that the sperm will not attach onto the sperm cells. You see, the HIV virus will not attach onto the sperm cells unless sperms are defective. So generally, a double washing is what is recommended, and there's been a large study which did talk about saying that when you do double washing of the sperms, we can actually do an IUI in the patients in serodiscordant couples. Female is HIV negative, male is HIV positive. We can do the IUI, but they've done a study also, and they've said that there's not a single transmission possibility. But they also insist that we actually do a double washing followed by a RT-PCR of the post-wash sample to make sure that there is no HIV virus present in that particular sample. So definitely, who are very insistent on this particular test can be done, but with knowing the risk and factor that there is still a theoretical possibility that there can be spread of this particular issue.
We had done a pilot study along with National AIDS Research Institute. That was quite a few years back when we used to get lots of HIV positive patients. Now, overall prevalence itself has gone down considerably. That time we had done a pilot study. It was not on a very large number, but there we had this proven that it reduces the chances of transmission.
Absolutely, sir. I think even the evidence to say that, but they still say even if the possibility is extremely less, even if you look at the ASRM guidelines, they do say that it's better to even go for an ICSI. Not that ICSI is going to change anything. ICSI is going to, when you're doing an ICSI, you're getting pregnancy faster, so the lesser possibility of mixing of both the samples are there.
And if you ask these couples, go and have an opinion from the infectious disease consultant. They even say if you are on an ART and if your CD4 CD counts are quite good, then they can also go for natural conception. That's what they are saying.
Correct. And everybody talks about advantages. Anybody can talk about the disadvantages. I think Sir had started off somewhere. I think sir is still there.
Rajesh
sir was there. He was actually did talk about some disadvantages, because most of us talk only about advantages of IUI.
Right.
Some,
you were saying about, you are mute. You were saying about the centrifugation, na?
Yeah.
Unmute yourself.
So I was saying that when that was when centrifugation, that depending on the how at what RPM it is being done, if it is going to be, it's going to vary. It's going to change the character and the morphology of the sperms. So probably that can also affect the results of the IUI or results of the sperms.
So I think
and the interpretation can be also different.
So correct, sir. So that's what I want to kind of bring an emphasis here, is especially when you're talking about IUI, again, you have to collect sperm. Again, collecting the sperm, the too stressed out, probably the 7 parameter might be bad. So collecting the sperm itself is probably a challenge. Once you collect the sperm properly, when you're doing excessive centrifugation, double density gradient, obviously you're actually causing some kind of a DNA fragmentation into your semen sample. Third thing is that unlike a natural conception where you actually do a trimmed intercourse and you ejaculate into the vaginal cavity, those sperms can survive actually for 2 to 3 days. Unlike an IUI semen sample where probably can survive only up to around 24, they say up 12 to 24 hours. What is the time of? And today people do IUI left, right, and center, and there can always be possibility of some kind of invasive, or they should always understand that it's an invasive procedure and that can also cause endometritis. So I think definitely, just like how we should understand the advantages, we should also understand the disadvantages of IUI, and also understand that you need to limit your procedure beyond a particular number.
So for this, I always, I also tell my patients of post IUI that they can have an intercourse that day or for next 2 to 3 days, like if they want, so it increases the chances of conception.
Correct, madam. Yes. So now I think the earlier session did talk about, this is kind of the last question. Is there any method to select a single sperm? We did talk about DNA fragmentation and how we are doing and how we are counseling them to do an IVF. Do you think you understand that there is DNA fragmentation? Do you think you have a technique in which you can actually select the sperm without a DNA fragmentation in this group of patients?
It depends on the expertise of embryologist.
Madam, but then
there are some sperm sorter techniques which are
devices
or methods which are available, like magnetic field is one of them. Then I think permeability is another one. So we have got zymote. I don't know
osmotic
commercial
membrane
names which are available. So sperm sorter, zymote, or magnetic field. These are the different methods which are available. So I think the principle I'm not sure about. There is microfluidic systems which are available and that they use.
Yeah. So I'll just in cut short say the different techniques that are available for sperm selection today on commercial available basis. One is PIXI, one is MC, then we have microfluidics, then we have MAX. We have these are the more commoner ones. Whereas your microfluidics and MAX and all are actually getting a cohort of sperms. We're getting a group of sperms, and we assume that the sperms which are escaping that in that cohort are probably having lesser DNA fragmentation. But whether we are able to select that one sperm, we don't know. Similarly, in situations where in PIXI and MC, where we actually select that one sperm, how are we selecting them? We are selecting again them thinking that the hyaluronic binding capacity of that sperm is probably the sperm that is having lesser DNA fragmentation. Whether it is actually the truth, we don't know. Till now, today, we do not have any technique which can actually tell us that it is going to improve your success rate or going to give you a specific benefit in patients with high DNA fragmentation. But we can obviously use these techniques in patients with repeated failures and high DNA fragmentation, but none of these techniques are proven and could not be said that this is definitely going to have any benefit. So I think I've been trying to kind of go very low on or go very basic on the kind of content that I want to discuss here, assuming that we might end up having a lot of youngsters and young gynecologists.
So can I ask a question?
Yes,
artificial intelligence is going to help it in the future. in future. I think that is AI is going to help much
AI
by
is coming up
selecting the
with
sperm itself. If you can put a morphology wise, then it's going to select the sperm for you.
there is
I think
something
that will be a day ahead in another couple of
Yeah.
years.
Instead of AI, if we do IVF, will it not select automatically the best sperm?
Yes, it will.
That's a natural good way.
Madam,
Yeah,
madam,
it will.
for a long time, the whole idea or concept of DNA fragmentation has come earlier in the sense that patients who are doing IUI, if there is a higher DNA fragmentation, go directly for an IVF. Was the concept that was started, especially in the Europe, and it was used as a technique or used as a modality under which they are able to counsel your patient and say that, okay, this is the reason you have to go for an IVF. But today we know that even IVF failure is because of high DNA fragmentation. Now, in this IVF for ICSI failures, when we talk about high DNA fragmentation, the question again comes, okay, we understand DNA fragmentation is the issue, but then how do we overcome that issue in this group of patients? That is again the question here. So for a long time, we always believe that when it's an IVF, it is selecting on its own. But now that the responsibility is on us to select the sperm, then how do we select it? That again becomes a question here.
Thank you, Dr. Poshuram. That was wonderful.
Sir, in case of
Thank you, panelists. That it was a very amazing one. There are a few questions in the chat box. One is, are antioxidants given empirically routinely to all infertile males? I think Parshu or Chaitanya can answer this.
And no, I don't think it's not given to routinely to all infertile males.
It's not given routinely to all, but for practical purposes, if you ask each one of us, probably most of them, 90%
They'll be very happy to have the placebo, sir.
Exactly.
Instead of saying no, we can give them something to
It has
eat.
it may have a placebo effect, but theoretically, as you rightly said, Dr. Porsunam, it's not given for each and every.
My thesis, during my MD, my thesis was L-carnitine male fertility.
But I will be talking everything about that only.
Because see,
one
one of the major concerns here in all these supplements is that the right dose, whether it's available in the right dose or not, is very important, and that's where we many of them, to cut down the cost of the product, they don't give you the right doses. That's the issue.
So what was the inference of your thesis? L-carnitine?
No, obviously it's MD thesis. No, I'll make proof.
It proves all MD thesis proves whatever the question is right, or whatever the intervention done was for the betterment.
But one of my professors, my father Gopinathan sir, was actually there for a lecture, and one of my professors asked him the same question. What do you think actually all these male medications are doing? He said it's giving you time. Like what's I was saying, it's very important. Time is sometimes
it's better than placebo.
Important.
I can say it's better than placebo.
Better than placebo. So you think that they're taking something, they're feeling good. Somehow they get pregnant, and we assume it is because of the medicine that we are giving. Why we need motile sperm for ICSI?
Or if they have to go for higher ART procedures, the acceptance is better.
Correct.
One more question.
See, how do we select a sperm? Technically, we need to have some motility to know that sperm is alive. Then we'll be able to select the sperm for ICSI. That's why we need a motile sperm.
But they've asked why you need why we need motile sperm for ICSI. That's one question from the
motile sperm is taken primarily to know that the sperm is alive. When there's an immotile sperm, I think Dr. Priya and Ramesh did actually have a clear, they did show up this thing of different techniques by which they're actually able to select live from the immotile sperm. So as long as the sperm is live, that is enough. No need to have motility. If there is the sperm is live, we can do an ICSI. With the whole idea of ICSI is that with whatever one sperm that is there, we can able to give pregnancy as long as there is a live sperm. Better sperm selection methods for ICSI in case of high DNA fragmentation. Technically, nothing is proven, but of the common lots that are easily available and cheaper, I would preferably use microfluidics in certain group of patients. We've had an MC machine for a very long time, so we have been using MC. But I would say for a routine purpose, I think microfluid has been giving good results because it's cheaper, not very expensive.
What is your experience with MC?
See, I personally have felt it is beneficial, especially in group of patients with repeated unexplained. See, we had started off the discussion saying that in which group of patients are we doing DNA fragmentation? If you look at all the studies which they've done about IMSI, they're actually comparing with, we're trying to imply IMSI into all population. But I think any technique that is formed, you should not try to or employ it on all our patients. You not get results. You'll have to actually categorize that group of patients. Unexplained in normal parameters, the embryo quality is looking good, the sperm is looking otherwise good, the egg is looking good. What is happening because of the evacuations that are present inside the head of the sperm? They say that the later development, or when the paternal activation happens, which is beyond your day three, that is what is getting affected. So actually what I felt is, especially this repeated unexplained ICSI failures, IMSI is benefited.
Then in that case, you will not get good blastocyst.
Yes. See, but that's what, blastocyst.
So unexplained infertility, wherein you are not getting good blasts in spite of good day 3 embryos.
Day 3 embryo, correct.
That
So
would be the subcategory of patients you would like to use IMSI.
So if you look at all the studies that have actually showed some benefit is comparing between unexplained failures is the category where they have given benefit. They've not shown any. See, when you talk about IMSI, we talk about morphology. So you think that severe abnormality sperm, we should use IMSI. No. In those group of patients, we are actually selecting relatively normal of the abnormal sperms. So still our outcome is not as good as what we get in other category of patients.
I agree.
Sir, I have a question. In case of oligospermia, patient is not willing, affordable for IVF. In that case, the pooling of post-processed IUI samples will help. There is mixing of the pellets finally. There is patient, and then finally mix the pellet to get the better concentrate. Will it help?
Madam, we've not tried that, but technically, if you look at it, again, you'll have to collect the sperm. You have to create a pellet that might not survive. I don't know whether
if the patient is producing 3 to 4 ml the same day is ejaculate, and that we use only 1 ml for processing. Why not we do a processing simultaneously?
Especially when the volume is good,
at a time.
Especially when the count is less, we'll have to use all the whole semen sample and process from that in multiple dishes, like what you were saying. Not only 1 ml, don't throw away the remaining. Take the other things and mix up. That is what technically we have to do. I think Dr. Parishit is also there.
Yeah, sir has just joined after emergency. So welcome, sir. Welcome, sir. Thank you for joining us. Yeah.
Again, my apologies for missing today. I'm very sorry for the mix-up.
So
But sometimes, you know,
week,
obstetrics is like that, and it just took much longer than what I thought it would. I'll be very happy to join all of you next week.
Yes, sir.
And
yes,
I wish all of the Foxians who are contesting elections the very best to have successful results. I can see Dr. Jairani and Dr. Chaitanya grinning very widely. Other videos seem to be off. So all the best to you. And I'm sure we'll catch up next week.
Yes. Thank you, sir. Thank you, sir. Thank you so much, sir. Next week, the same time, 25th, sir. We are again for another week with your talk, sir. Thank you so much, sir.
Done.
Thank you.
Right.
Thank you.
Thank you, Parashil, for that wonderful, elaborate, and very extensive male infertility. You have did like a PhD, everything starting from the basic to the very best DNA fragmentation and all your IMSI and other things. And it is so nice that we had Sir Rajesh sir, we had Chaitanya sir, and we had Aparna madam, and we have Kanchan. Everybody was so much nice discussions we had. Thank you so much for being a very big part of this wonderful webinar.
Thank you.
So
Thank you.
nice. Yeah, thank you. Thank you so much.
Good night.
Thank you, sir. Thank you.
Good night.
Mohana, thank you so much. Thank you. Thank you, Sheel, Chitrakala. Thank you so much for giving the platform.
Thank you so much.
On behalf of AMOX and on behalf of Oxy, I thank you, Sheel, for being with us, giving us a good platform. Dr. Kalyan is held up with an emergency, so he just asked to say his thanks also to you all. So
Thank you, madam.
Chitrakala. Thank you, Mohana.
Thank you, ma'am.
Yeah,
I'm very sorry for joining late.
Right.
I'm very sorry for joining late, but it was a very nice discussion.
No. You had a multitasking
Mix up
effect. That was very nice. That was amazing effect of any women. Anyhow.
Thank you, ma'am.
Thank you so
Thank you, ma'am.
Thank you.